Welcome to everyone, all the candidates who are giving the exams for the FRCOphth final. Congratulations on finishing all your parts. We know how difficult it is, especially as overseas candidate with no experience in how the NHS works. So me and Dr. Sweta, we are doing this RC of part 2 oral examination, mocks and preparation courses under the guidance of Prep Medico UK. So this is just a free taster mock session. So it's not very formal. It's more of open to all. So if everyone wants to participate, anyone who wants to just can raise your hand. We can sort of shuffle between cases, between people. So it has the entire structure of the Viva on and the OSCE, how they ask in the exam, what timings it is, how many minutes per station per session, and how the examiners are going to sort of judge you in the exam. So just a small mocks. And we will also, if time permits, me and Sweta, we thought we will enact a communication station so that you get an idea of how it is done, because that's one of the most, I feel like, the difficult stations that people go through, because we don't, trust me, we never talk to patients that way back home. So yeah.
Here you have to do it every day, every patient.
Every day. Every day with every patient you have to do this. So that's the only difference. So Sweta, I'll hand it over to you to take it forward.
So in this mock session, in the actual exam, you have 5 Viva stations plus 1 communication station. Usually the communication station's mark is calculated along with the OSCE station, but for the ease of timing and having the candidates go around in a circle, the communication station is conducted on the Viva session. That particular day they conduct it. And then each Viva station is 10 minutes. You have patient management 1, 2, investigation, attitudes and ethics, health promotion, and then you have the comms set there. So it's very easy to do 10 minutes each station with a rotation of candidates. And on your OSCE day, you have 5 OSCE stations. In each OSCE station, you have 3 patients or 3 substations. In that, it can be 2 videos, 1 patient, 2 videos. It can be of any combination, or it can be all patients. So it's not very standard, but it can be a mix. So you have anterior segment, glaucoma and lids. Then you have neuro-ophthalmology. Then you have strabismus and orbit. And last, you have posterior segment. These are the 5 OSCE stations. So instead of doing 3 substations each, we're just doing 2 for want of time and to be able to discuss. But we will take you through how it is going to look. We have added videos very similar to what we experienced in the exam. And then 1 communication station, we'll give you 5 minutes of preparation. So first one we will enact, and then one of you can volunteer to be the angry patient if you wish to, and one of you can be the patient, be the doctor communicating. And all of us can mark and give the feedback. That will also give a lot of ideas. And then this followed by feedback that I have on this slide, we'll kind of tell you after each station, so it's easy for you to understand. If we go to the end and then give you the feedback for every station, it's not going to stay. So that's one thing I modified. So we'll start with the Viva. That's how the exam works. You have your Viva first, and then sometimes you have 1 day's break, or you have half a day break, and then the next day you go for OSCE. That's how the exam pattern is. So the first station is going to be the investigation station. Who wants to go first?
Okay, I'll volunteer.
Okay, all right, well done.
So what am I supposed to say? Like the diagonal?
Just a minute. Did they have you put sub questions? Sorry.
No. So I'll just ask the questions. So Ahan, I want you to have a look at the investigation. Give me what investigation it is. Read the investigation to me step by step, and then give me the differentials, please.
This is probably a single field analysis of a right eye of a patient who is probably around 60 years or so old, done using Humphrey field analyzer probably, and the field does seem reliable based on the fixation loss, false positive, false negative error values within normal limits. Foveal threshold also appears to be okay, and what we are seeing in the total and pattern deviation here is probably superior quadrant anopia in the right nasal upper field probably suggestive of maybe um, right temporal optic tract fiber lesion, probably.
All right. Could you tell me the principle of this perimetry?
This is a static automated perimetry, which is I'm not sure. I'm getting under some pressure, I think. But
No, that's all right. Take your time to answer. You have 10 minutes. No rush.
But we all know that you know it. It's just
Yep,
how you put it in words is the matter.
that's it. Yeah.
mm, mm.
No worries. So, 1 second. So the next question, one minute. So what will be the indication for this testing?
This test can be done on baseline visual field assessment in cases of glaucoma. It can also be done for neuro-ophthalmic indications when you are suspecting any intracranial space occupying lesion, which particularly usually involves pituitary chiasma, optic chiasma near the pituitary lobe, but not necessarily just for that. In many other conditions, it can be involved. This field particularly involving a pie in the sky kind of defect may be suggestive of right temporal tract lesion. But we'd like to go with imaging and confirm if there is any space occupying lesion there.
So in this situation, given the patient's right in front of you, what more tests are you going to do? How will you examine the patient?
Okay, ma'am, do I get to know symptoms or just based on the field, or
Just
I
based on the fields. Just based on the fields. So you
um,
can just give me a very comprehensive sort of, it's not a big essay or anything, just very simple, very comprehensive.
just the investigations, ma'am, or
Clinical examination.
There's a
And
oh,
patient,
then
and this is the field that they've given to you. So
hmm.
what would you do next? So it can be anything. Do you want to ask what questions would you like to ask the patient? What are you going to examine? You can give me everything, but comprehensive way.
Okay. Um, this does I like to ask the patient on history of any eye drops usage. I like to second my inference. I like to change my inference in this maybe a glaucomatous lesion more than neuroophthalmic, given the field respecting the horizontal midline. And I like to ask history pertaining to glaucoma, whether the patient has any family history of unexplained blindness, whether the patient is on prolonged topical medications, whether the patient is on oral steroids or any other mode of steroids, to say for that matter. And I'd like to investigate the patient's anterior segment. I like to do gonioscopy and see the angle status, whether there is hydrotrabecular contact. I like to look for the optic disc, how is the stereoscopic appearance, and see for any neuroretinal rim based thinning, and the other tests. And also, I like to look for optical coherence tomography, retinal nerve fiber layer analysis, along with ganglion cell inner plexiform layer as well. And I like to see if the patient meets Anderson's criteria to diagnose the patient with glaucoma in 2 consecutive weeks, the standard HAP criteria.
would you like to go back to any question and answer again, or you're okay with the answer?
Um,
You still have a minute left. So the
uh,
question was what principle of
the perimetry.
perimetry? Yes.
So it works on giving a peripheral visual stimulus. It is automated and it has a threshold which can be determined by bracketing strategy, and to see that what is the minimum dens- uh, like illumination that is perceived by the patient. It can be measured in decibels. It is following the Blair's field of vision principle, with optic disc having a pit in island of sight in a sea of blindness. And I think I'd like to conclude with that.
All right. Thank you, Ahan. That was lovely. I'll go first with the feedback. And can we go back to the perimetry first, Sweta? Yeah,
Yeah.
just. So I understand that you covered the name, the date of birth, because identification is very important. Next comes the reliability indices. Always look at that first. And then I know you check the grayscale and the total deviation, but when you're always in doubt, you think it could be a quadrantanopia, it could be a hemianopia. Always say both in the differentials. Don't stick to one, because this does not respect the vertical midline. It's good that you corrected it later on, but when we correct it later on, then you also have to give the differentials for that. I think that was the
Understood.
only thing I found lacking, because you told the glaucoma, but then there are other for altitudinal field effects. We have to think of others as well. So here GCA is like a very, very important thing. It's like a baseline thing. GCA for everything. Yeah. So
Oh,
that's the only thing. But otherwise, I was happy with the way you went into the clinical features, the differentials, the examination history, and all that. Over to Sweta.
Yes, I was not sure. I've made a remark there. Did you mention it's a 30-2 threshold?
I think I saw it, but I did not.
Just comment. This is so when you start, just say this is a 30-2 analysis of the
Yeah.
visual field. And I can see these, but it was good that you told the foveal threshold. So everything that was methodical, that is fine. And exactly like how Shruti said, just say my differentials. So we don't go towards neuro-ophthalmology on your own. Just say this could be glaucomatous, this could be neuro-ophthalmology, or it could be like because it could be a superior quadrantanopia, like you rightly said. And also say it could be in other conditions like an ischemic pathology. It could be non-arthritic or arthritic AION. Just a small pointer in any station, if you have the possibility of mentioning GCA, because we have not given you the signs and symptoms the patient presented with. Usually in the exam, they might tell you this particular patient had this and then ask you the next question. If they don't, not mentioning a life-threatening disease in your differential would be a red flag in that station. So even if you do everything really well, they will still fail you.
Okay.
So
Understood.
think of giant cell arthritis with a non-arthritic AION could be a differential in this. I would make sure that the patient doesn't have this because it's life-threatening. And then I would also rule out these conditions. That would be how you answer. But
Understood.
otherwise, I think you did really well.
Yeah, you passed the station. Yes.
You passed this.
Yeah.
Glad to know.
So as Sweta was telling, the examiners have the capacity to red flag a station. So if they say you're red flagged in that station, that means you missed something life threatening. So that's the main thing. So from now onwards, every station I would tell all of you to do the life threatening differential first, and then go on from there.
Yes. Thank you so
Okay.
much.
You'll understand better as we go. But for your first time to try, you did very well.
Very well, yes.
Okay, ma'am.
I think one more thing we'll add is the examiners will never prompt you in the exam. They will not nod, they won't smile, they won't frown. They will have a very neutral look in the face, which is very off. It will throw you off your course. You don't know what you're answering. Am I doing it right, wrong? But that's unfortunately something that you have to deal with. But we are nodding along here. I will try not to do that.
Yes.
Yeah.
I think we are nice examiners. There
Yeah.
are some examiners who nod and who give you such positive feedback, but they mark you down. They give you
Yes.
marks. And there are some examiners who just have stone face looking at you and you feel you did really bad, but they would have scored you full. So the pointer here is just be confident with what you say, irrespective of the examiner's faces, and then just come out. That's all. Don't expect anything from the examiner.
So do we have our next person who wants to go ahead?
Oh, yeah.
I think Shastika can answer this. She might know this better.
Yeah, I know. Shastika, come on, do this so the others have an idea.
You're muted, Shastika.
I'll give it a try. I'm out of preparation for past 1.5 months.
So, right. Just give it a try. We will prompt you. Yeah. All right, time starts.
Okay.
So a 15-year-old keratoconus child wants to have a collagen cross-linking procedure followed by contact lens fitting done for everyday wear. But the parents are not ready to agree. The child is clear that his quality of vision with glasses deters his school activities, and thick glasses is an issue of self-confidence. The parents are concerned about safety and infection. So how will you proceed?
Okay. Since the age of the child is 15 years, I will check the gelic competency of the child whether the patient is having the mental capacity to understand about the procedure and to know the advantages and disadvantages of the procedure, whether the child is uh, aware of that, and if the child is willing to proceed. Even if the parents are not willing, if the child is giving consent for the procedure, we can proceed with the procedure with the consent of the child alone. And
Can you define GILIC competency for me, Shastika?
okay. In United Kingdom, covering England and Scotland and Ireland, there's a term called GELIC competence, where we will evaluate the mental capacity of the child when the child starts by age of 16, and we can do even if the child is having 14 years or 15 years, if the child is having the capacity to understand about the condition what he is having, and he should be able to repeat it and understand and give the full consent. So when the situation is, if the parents are not willing, uh, the consent of the child, we can proceed with the procedure. The child, if it is beneficial for the child.
So under the United Kingdom, in which countries can it be the GILIC competency can be overridden?
In Scotland.
And in which countries can it not be overridden?
In England, but in both the like if the we will try to convince the parents also in England, but in Scotland only if the child is giving the consent, we can go along with it.
And so in countries where it cannot be overridden, what are the other standby people who needs to be involved in the decision taking of child's health care?
We will involve the legal team. We will I'm sorry, I forgot it. Like we will involve the legal team and we will go through the process, and through the legal team, when the decision is made, we'll obey with those decisions. It is made via the legal team.
That's perfect. Any other questions, Sweta?
Other guardians, like
Yeah, I think that she's covered the important points, but you have a lot of time left, so you can probably elaborate a little more about how you will explain the safety and infection concerns to the parents. You will first try to convince the parents to be on board with you rather than go against their wishes. But if they are still going against the wishes, then you would you use the word best interest of the patient. So those are keywords that you used. In the best interest of the patient, which benefits the patient the best, I would go ahead. And I think country-wise, you were right. England and Wales is on one team, and then Scotland is on the other.
No, actually, the Scotland cannot be overridden, no matter what. Yeah, that was a bit of a confusion. I understand you need to just keep brushing it up. But England, Wales, and Northern Ireland, it can be overridden. But as Sweta was saying, you need to involve independent advocate who doesn't work for the trust or anything like that. And then you need to do a best interest meeting, and you need to assign a designated doctor for child protection. So safeguarding, you need to safeguard the child's rights. So these are I think the 4 words that we need to involve. But other than that, yeah.
I put on the chat box for people who are not able to follow the keywords: GILIC competency, independent advocate, and like I said, best interest of the patient. So full marks for telling you will assess the child's capacity. So in the first section and GILIC competency, you will score 3 out of 3 there. The only point where you might be marked down would be to say that you will counsel the parents, explain everything in detail, and try to bring them on board. And the next thing was a slight difference. I'm sure you will revise it before the exam. So you can override. Sorry, it cannot be overridden in Scotland, but you can still override in England, Northern Ireland, and Wales. Any doubts or any queries from the others who are observing or the participants? Was all the points clear, or would you like any clarification on this station? It's a slightly different one. Yes,
Can
yes,
I read
Merit.
it from Blue Book? Blue Book?
Yes, all this is given in the Blue Book. I think it's in chapter 4, if I'm not wrong. Yeah.
It's also there in the GMC guidelines if you want it for a more detailed version of it.
You're muted.
I think she got it. I think it's okay. So I know that this is one interesting thing because when we see the clinical presentation, we think it's like a clinical case. Are we going to take history? You can easily, trust me, just go into those aspects. But this is the moment the children's age is brought into action. It's about the Gillick's competency. So no matter how young the child is, if the child can able to understand, retain, and say back what they are going to have done along with the pros and cons and the risks involved, that means child is competent and can override the decision of the parents. But we always have to counsel them together so that the parents are in par with the treatment before we proceed. Not always. It would be better because any treatment a child has, it needs the support of parents, which is better in terms of economic and socioeconomic aspects. But other than that, yes, we need to say everything point by point. No matter what, this is how you go ahead with it.
Yeah.
All right.
So these are the key words that you will be marked on.
Yes, yeah. And they will always ask you where it can be overridden, where it cannot be overridden. So these things, just mug it up.
Well done, Shashrika. I think this station
Yeah.
you definitely pass.
Thank you. So who were we having next?
Next, who wants to volunteer? I think it's a health promotion station that we're going to do.
Anyone is
Oh, Mary?
interested?
I have no idea about attitude, health promotion. UK things I have no idea about. Sorry. I didn't start reading actually.
Okay.
Anyone else? Like, the topic now, you can just have a go at it, even if it might be completely wrong. It's all right just to, sort of set things in motion. Could be similar to what we practice in overseas as well, for all we know.
It need not be pertaining to here. You can just.
Yeah.
So just to make things clear,
So I can say about the
not everything in the blue book usually comes. Like when I gave the exam, it was a completely different station, which I have not read about at all. So it's fine to put yourself in the exam situation. Sometimes you might encounter things that you have not prepared. Quickly use your common sense, try to say as much as you can. You might still pass that station. So if you want to give it that way and attempt, you're free to attempt.
so if a woman with diabetes is planning for pregnancy, I would like to do a screening examination of the lady for ruling out the diabetic retinopathy.
Okay.
If diabetic retinopathy is present, I would like to do repeat examination. If it's it's based on the grades of the diabetic retinopathy. If it's a mild to moderate LPDR, I would re-examine. I would observe and re-examine the woman at the start of first trimester, then again at 20 weeks, and again the final examination at 28 weeks. And if it's again, if the woman is not having diabetic retinopathy, I would do my repeat examination at the end of the third trimester, which is around 28 weeks. There is no need to repeat examinations at first trimester again and 20 weeks. And if she has already developed proliferative diabetic retinopathy, uh, I would do a treatment of pan-retinal photocoagulation prior to planning start of the pregnancy, and then monitor every, I'm not sure, maybe monthly. And I would refer the patient to a physician for good control of good glycemic control. And I would avoid that's all, anti-VEGFs and other lasers during pregnancy. So I would complete all the 3 sessions of pan-retinal photocoagulation prior to the start of pregnancy. That's all I remember vaguely.
What extra precautions would we take during, say, it's a pregnant woman coming to you for evaluation, for a clinical evaluation? What is the extra precaution that you would take?
So I would avoid drastic control in blood sugars, and also I would avoid anti-VEGFs and pan-retinal photocoagulation. But vaginal pregnancy is not a contraindication for diabetic retinopathy.
Any other point you'd like to add?
That's all I can remember.
When would you like to see, once the patient has had the baby, when would you like to follow up the patient?
Till 6 months postpartum, I would follow up the patient.
All right, Sweta, any other questions from your side?
Are intravitreal injections in proliferative diabetic retinopathy contraindicated in pregnancy?
Yes, they are contraindicated in pregnancy because it might affect the growth of the uh, intrauterine fetus and blood supply to the fetus.
Okay. I think where is that one? We have another 4 minutes to go.
These are the few lines that I read in Blue Book. That's all that I know about. Half a page in Blue
So,
Book.
yeah, so you have, I mean, you have actually covered quite a bit of the important aspects of the screening program for diabetes in pregnancy. Only thing, I mean, I think you said the first trimester, the third trimester, and an examination in between the second trimester, if I'm correct, if they have DR. Is that what you had mentioned? Your
Yes, if
voice
they
got cut
have
in
DR,
between.
start of
Mm-hmm.
pregnancy 20 weeks and 28
Mm-hmm.
weeks.
All
And
right, that's
if
perfect.
they doesn't have DR, start of pregnancy or prior to pregnancy within 3 months of prior to pregnancy and at 28 weeks again.
That's perfect. So you also mentioned that PDR should be treated before pregnancy because it can affect the fetus development. The only thing I was prompting as well as for the drops administration because we need to avoid phenylephrine, just plain tropicamide for these patients. So yeah, that's all from I think. But otherwise, you did the station quite well. We are just trying to
So
keep the short stations. Yeah,
can
go
we do
ahead, go ahead.
PRP? Can we do PRP during pregnancy?
I think it's a bit of a gray area, but mostly they tend to avoid. Again, it's because it's a painful procedure. It's not anything directed to the fetal, but because of the discomfort and the pain.
And I have read somewhere more chance of all this inflammation, choroidal detachment, and all during pregnancy while doing PRP. Not in Blue
Exactly.
Book,
So
somewhere else.
yeah, so the main thing here is you just need to tell them that PR, no, any procedure is contraindicated in pregnancy because it is going to be affecting the fetus. That's the main thing. They won't go into the clinical, questions in terms of what is the, mechanism in which it's going to cause any fetal issues or anything like that. So don't worry about it. But it's all like a gray area. Main thing they're going to ask you to cover is when you're going to treat and when you're going to examine, and as you mentioned, avoid rapid optimization because that can worsen the DR status of the patient. And sometimes they might question you whether you would prefer a C-section or a vaginal delivery for this sort of patients with diabetic retinopathy. You just need to you answer that correctly. There is no contraindication, and then we review after 6 months. But other than that, nothing more that you need to worry about in DR and pregnancy.
So
Um,
just to give you an insight, if this is a station, they might not directly ask like how we have put it. So first they would give you a history, and then you have to come to the diagnosis that it is diabetes, diabetic retinopathy, planning and pregnancy, and then they will ask you step by step what would you do. So it would be a 4-part thing in the station, and each part would be marked by 2 examiners. But the crux of it is this: once you have told, and they might ask what is the reference on this, and you should know that this was done and this is the reference. So do some reading on this topic, extra reading. Don't depend completely on only what is in the Blue Book, just a little bit extra to just widen your horizon on this. But otherwise, all the key points were covered. I think you did very well.
and don't worry about finishing
So,
early in the exams. Oh, sorry, go ahead. Yeah.
so suppose you get a topic, any topic, that you already know you can talk only for 4 minutes. So, do you have any tips to extend it to 10 minutes? Like,
That's what I was going to cover. So I have actually sat outside Viva stations, finished very early, and just been like, oh, that's it. There are no more questions and nothing more to talk about. Sometimes examiners are, if you have hit all the right points, like the keywords that are provided to them, they are also happy. They just be like, yeah, you're done, and then you just wait outside. That's it.
Yeah, either you've told all the keywords
or you're not told
not
anything.
even reached the diagnosis that they've sent you out. So it can go two ways, but don't worry about it totally. But if you want to extend, you can just say, I will do a complete ocular examination, make sure there is nothing else. You can say, like, I will make sure I will do gonio, make sure there's no rubiosis. So you can say, like, I will do a routine ocular examination from anterior to posterior segment, grade my diabetic retinopathy, plan treatment follow-up plan throughout her pregnancy, counsel her for the same, and then you can put all these extra fittings in your answers and then say, I will plan the visits at this week, and this week.
And even in the worst case scenario, they're like, okay, PDR is there. How are you going to treat? You can always say that it is beyond my scope of treatment protocol. I would involve the help of a medical retina profession or a VR surgeon, because it's involving both the mother and the fetus. So also be like a multidisciplinary approach, because we will involve the OBGYN. You don't really need to answer that because it's a gray area. So
yeah. So this one, any answer that you are not sure of, always add this term. I would take the help of my retina colleague in this particular case, considering it is a pregnancy with diabetic retinopathy. It would be a multidisciplinary approach with constant communication between the obstetrician, my retina colleague, and me. Here in the UK, it is not about you knowing everything. It is about you being safe. So you telling you will get help or ask for help will earn you marks in the exam. So in any station, once you see what is on the screen or the iPad the examiner shows you, one part of your brain should immediately think, which other department am I going to ask help from? So in every case, you can say, I will involve this particular team's help in managing this patient. So they know you're safe, you are going to ask for help, and that is a very important thing to score marks. Even if you don't know the answer, I think I told in few stations that I would ask the general practitioner or the microbiology team's help because I didn't know the answer. So that's fine. They knew even if I didn't know, I'm not going to do something stupid. I'm going to ask for help.
All right, I think we have Ayman Ghanem who's raised his hand.
Yes.
Yeah, it was a nice case actually. Just I want to, you most probably you have answered my question, but just for knowledge, it's a good point to mention that anti-VEGF is contraindicated in pregnancy. But what about lactating mom? Is it contraindicated? Just for sake of knowledge, I know it maybe they might not ask this question, but suppose if the patient has a significant macular edema, diabetic macular edema, and she was lactating, mom, I can simply say, as you said, I will discuss that with the VR surgeons, take the second opinion. But just for knowledge, is it contraindicated the anti-VEGF in a lactating mother, or she can have it normally?
From what I have in limited knowledge in this discussion with my medical retina colleagues, they do say it is contraindicated because it can go from the mother to the fetus, and anti-VEGF, it has its own risks. Yes. So, but then I'm not sure if I think it is a category C drug, if I'm right, anti-VEGF. Yeah. So.
Yeah. Okay. Because I have seen this case actually in one of the injection clinics. She was lactating, but yeah, I just referred her for a second opinion for retina, but I missed the follow up, so I don't have the clear answer whether it's contraindicated or not. Okay, thank you for that.
Thank you so much. Thank you for the insight. I think at the moment we can say it's contraindicated.
Yes. So any question where you don't know, it's exactly how I told earlier and how Heyman rightly pointed out. You can say, I will ask for a second opinion, weigh the risks and benefits. If it's like a very severe thing, sight threatening, and it definitely needs to be given, it's a different thing. So weigh the risks and benefits, have a second opinion with my retina colleagues, and with a multidisciplinary team approach, I would consider whether to give or not, but largely it is contraindicated. That is a very set answer you can use for many other different things as well.
Amazing. Thank you so much.
Yes. Okay. Going on to the next patient.
Let's put the timer on. Who are we?
Yes, who's what?
Who's volunteering? Uh, it's a patient management station, so should be a pretty simple one.
We have a lot of observers, so the observers can also raise your hand, and you can go take a guess at one of the stations. It's fine.
It's mostly the high yield stations, so you should all be mostly familiar with it. If
Yeah.
anyone wants to go on.
But if you're
I
going to
can.
go and cycle, it'll be Ahan next.
It's like I did not sign up for this.
Yeah.
All right. Go ahead, Ahan. Yeah.
Okay.
So it's a 70-year-old female patient. She presents with reduced visual acuity unilaterally, and it was associated with abrupt headaches with scalp tenderness. She also gives a recent history of fatigue and weight loss. How will you proceed with this patient?
Um, an elderly patient presenting with such complaints, I'd like to investigate for the cause of headache. I'll consider giant cell arteritis as a very strong differential given the presence of scalp tenderness. I'd also ask her whether she has pain while chewing. And I'd like to clinically first assess the patient whether she does point to this diagnosis of GCA, and that can be asked for pain while combing the hair, or whether she has jaw claudication. And if those signs are present, those symptoms are present, and the patient's anterior segment followed by posterior segment has to be evaluated comprehensively. I like to see whether there is a relative efferent pupillary defect, first of all, and in the posterior segment, I'll be expecting thorough posterior segment evaluation with the focus on optic disc, whether there is the presence of disc edema, whether there is parrot disc edema involving the full disc, and given the recent history of fatigue and weight loss, uh, I'd also like to consider other differentials, probably along the lines of any paraneoplastic etiologies or any malignancies. And I like to assess the patient by getting systemic evaluation by a physician friend. Having a multidisciplinary approach will be very helpful. The patient, whether the patient, if presenting with disc edema, scalp tenderness, jaw claudication, uh, this means this is an ophthalmic emergency. This is actually a very important point where we should actually send investigations like complete blood count with ESR. We can see whether the patient exceeds the age-matched criteria for ESR, and then based on GCA's ULR classification, if we see that more than 3 out of 5 criteria are meeting for the patient to be diagnosed as GCA, which can also be done without actually doing a temporal artery biopsy, we can proceed with starting the patient on intravenous methylprednisolone, which actually prevents the other eye from getting involved, which happens usually in 70% of the cases. Another recent study shows that tocilizumab injections can be given. So I'd like to get immunologist opinion involving a multidisciplinary approach as soon as this condition is detected. And via joint approach, I'd like to start this patient's treatment on immunosuppressants for the prevention of attack in the other eye. And apart from that, I'd like to rule out any other GCA related predilections that the patient may have, polymyalgia rheumatica and all. So as um, the need is, I'd like to get an immunologist opinion, and by a multidisciplinary approach, I'd like to proceed from this scenario. Differentials being paraneoplastic conditions, and even whether there is any history of diabetes, hypertension, can be helpful in evaluating other etiologies which may be there. Uh,
Any other examination that would you like to perform in these cases?
Investigation or examination, ma'am? Examination.
Examining.
Okay. Fundus fluorescent angiography can be very helpful. It will help us, and even optical coherence tomography with angiography can be a very non-invasive alternative for that, given the recent advances. And I'd like to see whether there is, in case of FFA, whether there is a delay in disc filling and whether there is diffuse disc leak. But in case of optical coherence tomography, I'd like to see whether deep capillary level perfusion is affected, and I'd like to evaluate the patient's
Oh, that's
tone.
okay. History, you try to ask everything. Anything else would you like to ask? You ask for jaw claudication, you ask for scalp tenderness, pain, all that is fine. Anything else? Any important systemic history you'd like to ask? Recent events?
I'd like to ask the patient whether the patient has had any episodes of recent hemiplegias or transient ischemic attacks. And that will be helpful because that does show that the patient not only has ophthalmic artery involvement, but other large vessel involvement, which tends to occur in giant cell arteritis.
So
And
examination-wise, what would you add there?
I like to have a neurological examination by the patient's tone, power, and even sensory examination uh, with deep tendon reflexes. And I'd like to have a neurologist uh, uh, opinion, having a multidisciplinary approach to this patient's vasculitic etiology, which seems to be there.
Okay. I think you covered most, that's fine. So I think largely correct. In the terms of UK examination, two things that you need to remember is the minute you say GCA, add the keywords of telling I will examine other cranial nerve involvement. Make sure that the patient does not have TIA. I prompted you for that, right? That is another important thing. And you will say you will contact the stroke team to rule out that there is no acute pathology that is going on. The stroke
Yeah.
team being contacted is very important for you to tell in the examination. But very good on picking up GCA and going on step by step. And excellent on telling about tocilizumab. And when you give percentages, try and give a range. I think few books give 70 and few books give 95% recurrence in the other eye. So just say more than 70 or say 70 to 95.
Range.
You want a key examiner to mark you down just because you gave a number.
Okay.
RAPD was there, others, everything. I think ocular examination wise, you covered everything.
Okay. Thank you.
Yeah, you did really well, Ahan. So I think one point we want to mention to you guys is once you finish, like say you won't be given a piece of paper with the questions in order. It's going to be the examiner asking you the questions. So I would suggest once you answer the first part, like the first question when it's thrown at you, just wait for the examiner to ask the other question, because otherwise what happens is even once you finish answering, the examiners need to ask all the questions in the list that's given. So imagine you would have just finished the entire answer, like, yeah, I examine the patient's neurology, and then they will just throw this question at you. How will you examine the patient? So for you, it's like, did I miss something? But you wouldn't have missed anything, but the examiner needs to ask the question. So just
Okay.
wait for a second, like a beat, so that I've had this happen. I'm like, oh God, did I actually miss something? You wouldn't have missed anything, but examiner has to ask the question, because otherwise it's an error like on their part. So that's one thing just for you guys to think about. So I think what Sweta was telling, like stroke team send referral, it's a trust policy that varies between trust. You can also use the word like I would depend on the trust policy in terms of referral, because in our trust, we refer urgently to the rheumatologist, and they decide if the patient wants to go to stroke or they just stay with them. Sometimes they just do an ultrasound and decide, okay, everything's normal. You can also mention ultrasound of the temporal artery, but that's again multidisciplinary. We don't care about it.
So like you said, use that same term, multidisciplinary approach, involving a
That's it.
neurologist, rheumatologist, and
Neurologist, yeah.
team.
So
And I
you can
wanted,
also add like trust policy, based on trust policy. That's it. Yeah.
Yeah.
Go ahead with
So
that.
make
I
notes of that.
have to go through the blue book. I understand, to go through all of these details, because what I think I'll be missing out on is UK specific things, which, as Shweta ma'am mentioned. So will that be enough, like as I go on with my October exam, or like Anything else is needed?
The main aim of our platform to help with exams is to make you familiarized with the UK terms
terms.
that you need to use.
Okay,
So
ma'am.
we will help you out. We will tell you the most important things as much as you need to know. And try and read. We are making a library of all the guidances that you need to read for the exam. That will be out soon on our platform as well. So that should help you.
Thank you so
So
much.
certain answers, just formulate in your head and keep, which you can just use, substitute words and used in all stations. Like according to the trust policy, I will use a multidisciplinary approach. I will ask the help of this team and that team to do this. And sometimes in few stations, I couldn't remember the systemic involvement. Like I had this angioid streaks and completely blacked out in that station as to what I'm going to say for the systemic associations. So I just said I would rule out any life-threatening associations after consulting with my medical team. So there they can't fail me. I just didn't remember the words, but I've told it because I know there is an association. So these are small things. They can't mark you down. Maybe 1 mark they will lessen there, but they can't fail you.
Yes.
Okay.
So if you blank out and you know there is something, just use that word. I would rule out life-threatening associations with this using my help from my medical team.
Okay.
Yeah, that's so I think in the blue book is like it's like a basic,
A
how
backbone.
would I say? Yeah, it's just a backbone, but you need to elaborate more. So I think that's where there was this all these handbooks like Oxford. There's another one also. I'm not remembering the name. If I remember, I'll put it in the group and send you guys.
In more fields
So,
manual.
no, not that one.
Okay.
And there was another one which I had, which was very nice and short and easy.
Yeah, so we will share the links
Links
to
and
these
everything.
guidances and policies which we are compiling soon. Okay.
Okay.
Within a
Thank you.
week, we will send it over. Don't worry.
All right, guys. So we'll go to the next patient management. So 2 patient managements we have. So we'll go for the next one. Who are we having? Merin or I think
Shastika, you want to do one? Patient management, I think you'll be fine.
Hi, yes, ma'am.
Okay.
Yeah, this is. All right. So, Shastika, the second patient is a 55-year-old female patient. They present with sudden onset of pain and loss of vision in her right eye. She's also experiencing severe headache with eye pain and vomiting. So how will you begin to manage with this patient?
Okay, I'll start with history taking, and I will examine whether the patient is having a raised IOP. I will measure her IOP. In history taking, I'll ask whether she's already on any anti-glaucoma medications or she has undergone any recent surgeries. My top differential diagnosis would be an acute angle closure glaucoma. So if the
how
IOP,
will you? So next question. So how will you examine the patient?
first I will examine her from anterior segment to posterior segment. We'll start with the corneal examination, check whether the corneas are clear or hazy or edematous. We'll check whether the anterior chamber is shallow, and we'll do a gonioscopy to rule whether her angles are closed or open. Then we'll measure her IOP if it is raised or it is normal, or
Any other examination of the other eye?
okay, if it is angle closure glaucoma, the other eye also would have a shallow anterior chamber, and the gonioscopy also would have a somewhat similar findings. Or whether the patient has undergone any recent surgeries. Since the patient is experiencing eye pain and vomit, I would go with the angle closure glaucoma.
Anything else you would like to notice? You spoke about the cornea, the IOP, the angles. Any other thing that would help you plan the management? That's okay. Say this patient has 60 millimeters of mercury as the pressure recorded in this eye. How are you going to proceed with the management?
Okay.
And the angles are shallow.
Okay. If the IOP is 16 mm and angles are shallow,
0.
60. Okay. Then it would be angle closure glaucoma, which has triggered, and she would have got the eye pain and vomit. So initially, I will start with anti-glaucoma medications. We'll start her on. We'll check her blood pressure and we'll do an ECG to her. Make sure she's not having any cardiac issues. After getting physician opinion, we'll start on mannitol to reduce her IOP. Then after starting mannitol, we'll do an okay based on the ZAP scale. Can do an YAP peripheral eye adaptation for her. Since the patient is having already age is 55 years, if she is having a cataract lens, we'll go with a lens extraction.
Any
Then,
other treatment for the patient?
Since the other eye also is prone for acute angular pressure attack, can do an prophylactic YAC for the patient. If it is a cataract lens, can go for lens extraction.
All right. So I would like you to comment on the PAX plus criteria.
Okay. Should examine the fundus to look for disc changes, look for disc cupping. PAX plus criteria is for like I'm not getting it. Like
No.
only for those criteria patients we need to give YACP, not for all the patients. Like only
just
the angle closure is
If you don't recall, just tell that one. Tell what you know.
the angle closure is like if the angles are closed in more than 3 angles, and if the like if the IOP is more than 40, and if there is a disc changes, I'm not sure. Only for that criteria, the patient who fit into the PAX plus criteria, only for them we have to do YAP.
Yes. So, and what is PAX minus criteria? It's all right. So if you know, you know. If not, it's all right. It's okay. These are just extra questions. Any other questions, Sweta, you want to put forth?
No, we started with ZAP, so probably they will ask that.
That as well, yes.
That as well. Okay, so you did cover the major points, but it needs to be more organized. Don't leave it for a prompt, because they will mark you down telling that they prompted or you are unsure. It would be the remark that you get on the answer sheet would be was unsure, unstructured answer. But you would have actually told everything. So structure it. And history-wise, ask if they've had any previous attacks, previous redness, watering.
Lasers.
You need to know if they've had any intermittent attacks in the past. Then examination, you said cornea IOP angle. You have to mention lens status. You have to mention disc, because that is also important to whether your diagnosis is PSC, PSCS, or PSCG. So then you have to say intermittent attacks, and you have to look at the disc status in both eyes. That is very important for the diagnosis. You mentioned IV mannitol. My suggestion here would be to say intravenous or oral, or just say systemic IOP lowering agents like IV acetazolamide or mannitol, because again, trust policy, it varies from person to person, place to place, and largely they use IV acetazolamide rather than mannitol, like how we do back in India. I understand your confusion there, but to be on the safer side, use the a broad terminology telling systemic IOP agents. And then along with that, here they give anti-glaucoma drops as well. I understand you didn't tell because the pressure was high, it's not going to absorb, but no, just say I will add topical anti-glaucoma medications. Then once the pressure is lower and the cornea clears, I will attempt to do a YAG peripheral iridotomy. Or if the patient has cataract, doing a cataract surgery helps. And the other eye prophylactically PI. I think Shruti had to prompt you for that, so you'll be marked down there again. But the thought process has to be quick. A very nice table is given in Oxford Handbook for this management of acute angle closure. So everybody appearing for the exam, try and see. We will also be posting that in the group soon. But yes, so the reference for this for step-by-step management is an Oxford Handbook for acute angle. So the recent NICE guidance on acute angle closure is very important for the exam. Any of this can pop up. Oh yeah, Shruti's already put up from here.
Yeah.
The third thing. And then you have, you don't have to read the entire NICE guidance, which is 20-25 pages for each condition. Everything will have a summary. So go through the summary and make notes so you don't forget. The PAX Plus is very, very important. You have to know it in the tips. That 6 to 7 points you have to tell. Even if they wake up from sleep and ask, you should know it. It should be at the back of your hand, this one.
Actually, PAX Plus could be an health promotion question as well for you guys. PAX study with the PAX Plus can be like a health promotion.
ZAP trial with PAX is a health promotion station, very often asked. Somebody have their hand up. Yes, Merin.
So, in India, when the patient is presenting with acute angle closure attack, we do the fellow eye PI on the same day of presentation. So, in NHS, when do we do it, fellow eye? On the same day, or do we wait for?
Same day.
Same day, same day.
Okay, even if you are not doing the affected eye on the same day, you can do the fellow eye, right? First.
Okay, that's a good question. So I can understand where you're coming from. So corneal edema doesn't clear and we're not doing the laser today. We don't do one eye today and the other eye the next day. We just book them together. It's mainly in terms of time and resources. But you can say trust policy again, because trust me, every consultant varies, every trust varies.
And
So.
you're not wrong in doing the prophylactic today, then doing cataract extraction in the other eye the next day. So yes,
You can do it,
technically you can say yes.
Okay.
There's no wrong answer for that, actually.
Yeah. And they will not nitpick you on these things. They are more worried about just the flow chart, and they'll ask you about PAX Plus and PAX Minus. That's all.
And even in terms of systemic IOP lowering, if they are very persistent, they're pushing for a specific drug, always stick to IV acetazolamide, because we don't use IV mannitol here. It's a very last resort medication. Unless the the renal function is affected, then we go for IV mannitol. So, and we don't really, I think what Sashtika was telling was more in terms of what I followed back in India. The moment I stepped here, it's purely Diamox. We give, sometimes we just give oral Diamox 500 milligram and
500 milligram.
Yeah, sit there for half an hour.
Yeah. If it's like 45 and all, I've not resorted to IV, because there might not be staff who want to, who are very competent with IV, and then I don't want to go and attempt on a patient, which I've done years ago. So I give oral and I wait.
So we do the basic ECG, then we'll check whether the patient is having cardiac risk or whether the patient is.
No.
Nope.
Have to ask history-wise, systemically stable patient. Just so to cover all bases, just say make sure they don't have renal, cardiac.
Renal and cardiac.
Make sure it's safe to give the acetazolamide, and I will give. That's all.
That's it.
Be very practical. Don't elaborate and waste time there.
Or get stuck in a loop where we don't know the answer for.
So don't say ECG and all. Say I will make sure there is no associated cardiac or renal risks. And when safe to do so, I will give the IV acetazolamide. That's all.
Because terms like NICE guidelines is a protection one. Sorry, go ahead, Ahan.
Very informative, ma'am. I just had one small doubt. I wanted to ask whether I know the examiners will remain the same, the guidelines remains the same. However, for candidates giving exam in UK versus candidates giving exam in India, let's say I'm attempting Delhi exam this year. Do the answers have to vary based on the local practices by even a small fraction, or does it have to be very the same? Because that's how I've been taught. So I just wanted to get that clarified.
FRCOphth is a UK qualifying examination. The examiners in the exam are going to be from the UK. Maybe one or two might be from local area, but the answer would be from NICE guidance.
Okay.
Because this is an exit exam for ophthalmology in UK. The moment you finish this exam, you are eligible to practice in UK. So they want you to know the UK standards and guidelines. So it will not be India based at all.
Even if you give in Singapore or Malaysia or Pakistan or India, doesn't matter. The answer should be from the NICE guidance in the UK.
Understood. Just wanted to clarify. Thank you.
No, yeah, that's
a
a
very
good
good
question,
question.
actually.
Yeah.
Yeah. So this almost this packs plus also, so it's like in terms of your what else, health promotion, where anywhere else it can comes with a
Yeah.
packs.
Attitudes, ethics also. They can,
Attitudes, ethics as well, it can come.
so this is very important. It can come anywhere. It can pop up in your glaucoma and lids station in your OSCE as one of the last questions, last section. So there are few things which cannot escape the exam, which is thyroid, third nerve palsy, this one, PAX plus, the light or the ZAP trials. So these are things which can sneak in any station in OSCE or Viva, or it can even come in the comms. So you just have to be very, very thorough with these.
Yeah.
AMD as well.
Oh, AMD is a very tricky one, but we'll get there. All right.
Yeah.
So next one, I think we're doing attitude ethics. Is it?
No, we're
Oh,
going
we're done. Oh,
yeah,
we finished that.
Viva. We're going to the OSCE next. So the OSCE would be 5 stations. So in anterior section, we'll have 2 cases. Glaucoma and lid, we'll have 2 cases. Strabismus and orbit 2, neuro-ophthalmology 2, and fundus or the posterior segment 2. So I'm just asking openly, what would make you feel better? Do each one of you want to do one particular station? Like one person wants to do anterior segment fully, or you want to do keep rotating, whatever suits you.
I think we'll.
I think somebody put the mic on. Anybody, just go on.
You can go ahead, whatever you like to say. Yes.
Yes, I think I'm Bina here. I think
Bina.
I would like to do one possible scenario from different sessions.
All right. Yeah.
Okay, all right. We'll do that then.
So we have Bina as volunteer. Anyone else?
Anyone else? Same people can also do. Just raise your hand when you want to do, and then we can go on.
Shastika's willing, and Ahan's willing.
Excellent.
Yes.
Okay. Bina, would you like to go first?
Yes, sure.
Okay, and Marin's also willing. Yes. So
Yeah.
okay, perfect.
So shall I start?
So yeah, all right, Bina. So our first question for you is explain the clinical picture for me, please.
Okay, this is the anterior segment photograph, color photograph of the left eye, possibly showing some congestion of the conjunctiva. Cornea is clear, but I can see a round endothelial keratoplasty graft with interrupted suture temporally, and I can see a gas bubble up to 30% fill in the anterior chamber. The anterior chamber looks deep. The cornea is the pupil is dilated. It appears to be pseudophakic eye. So my top differential diagnosis would be a post-operative photograph of the endothelial keratoplasty, more likely to be a corneal endothelial graft.
All right. So you covered the clinical features and differentials. Could you give me the indication for this procedure, please?
So the most top indication for this procedure would be Fuchs endothelial dystrophy, any pseudophakic bullous keratopathy, phakic bullous keratopathy, any other corneal edema, non-resolving corneal edemas. Then these are the main top differentials for this procedure.
Could you give me the contraindications for this procedure?
So the contraindication for this procedure would be any other corneal opacities involving the stroma, which are going to affect the visual. If patient is like keratoconus and they had acute eye drops, or any other corneal pathology involving the endothelium and stroma and other layers of the cornea. So that will not be cleared with this procedure, and the vision may not improve. In these cases, there is no point in doing endothelial keratoplasty.
Can you give me the complications of this procedure?
So the complications are intraoperative complications and postoperative. The intraoperative complications which could happen is the graft may not unfold as expected, and there could be damage to the graft during the unfolding procedure, depending on the surgeon's skills. If they are a novice surgeon, they might struggle to implant the graft, and that could lead to loss of the endothelial cells and primary graft failure. Secondly, we have to place a SF6 gas or air in the antechamber to attach the graft, and that itself could raise the eye pressures intraoperatively and cause acute glaucoma in the patient. Third problems which could happen is the graft can dislodge and go to the posterior segment of the eye. Then the other complications are post-operatively. Immediate post-operatively, patient has to lie flat, and that can give them some postural problems. If they are already having some neck problems, that can be an issue, that they cannot lie flat, and the effect may not be as expected. The graft may detach early during the post-op period. If the eye pressure is raised, we have to release some of the gas from the antechamber. Other things which could happen post-operatively is early detachment of the graft failure, and the patient may need rebubbling post-operatively.
All right. Thank you, Beena. That was
Thank you.
nice presentation. So coming to the points, yes, you did very well. Clinical features wise, I think you did not mention the suture, if I'm correct.
Yeah, I mentioned it
Oh,
that
you
there is
mentioned it.
Yeah,
All
she
right,
did.
sorry, I
Yeah.
think I missed that. That's perfect. So you mentioned all the findings, everything was well and good. So possible diagnosis, you went with the lamellar graft, so that's correct as well. But one thing we also have to mention is the host tissue, how that looks, because when you examine comprehensively
Yes.
limbus to limbus, you have to mention how the host tissue, because that will give you an idea of what was the reason the grafting was done.
Yes, the cornea overall looks fairly clear.
Yes, so centrally, but if you look peripherally, it's a bit more hazy. So you have to look for
Yes.
guttae. Sometimes they expect you to look for guttae and stuff in the host cornea as well. So other than that, indications, said most of the important stuff. But regrafting they do here. They do endothelial regrafting many times here, unless there is scarring as such or recurrent failures. Contraindications, you mentioned towards the end about the postural problems. So if patient has postural issues, then that also they consider a contraindication. So we need to think about that. And a few more like aphakia, aniridias, glaucoma surgeries, and all that we need to involve. Complications wise, you were very comprehensive about it. Did you mention about the endophthalmitis by any chance?
No.
No. So any always infection, IOP,
Okay.
all
Yes,
that
infection.
complications.
Yes.
Yes, that's all. I think from my side, I'm happy you definitely passed the station. Just a
Thank you.
few points here and there.
Yes,
Anything from
thank you
your
very
side,
much.
Sweta?
I agree. Bina, you did very well. Definite pass in this station. The only place I've reduced mark is you never mentioned DMEC. You said endothelial, most
Yes.
tech,
Me
but
sorry, in this scenario, I definitely felt it is a DSEC
yes,
because
I
the graph looks more
but
thicker at the
exactly. But
edges.
the exam, when you say differential,
Differential, DSEC
yes,
or DSEC.
it can be
Yeah.
DMEC, PDEC. It could be any of the endothelial keratoplasties.
Yes, yes.
So mention the differential, and the other mark that I scored you low was for not mentioning intraocular issues like aphakia, aniridia, previous glaucoma.
Yes,
Because if there is a tube or a trab, the air bubble will not fill the AC, and you will not
yes, yes,
just that. But otherwise, you passed and you did really well. Good flow and good structure. I liked the way you told intra-op and post-op complications. That's a very good
yes.
take-home point. Very well done.
Thank you very much. Thank you.
All right. So I think Ahan is next in line. So without delay, Ahan, you ready?
Yes, ma'am.
So same way. Start with the clinical picture, please.
Okay. Starting from the adnexa, the eye appears to have a certain amount of congestion in the conjunctiva, probably suggestive of maybe post-operative congestion. And coming to limbus, there is superficial vascularization noted almost 360 degrees. In the anterior segment, the cornea appears fairly clear. Anterior chamber depth can't be committed but appears adequate. under this diffuse illumination the photo, and I can see there is an anterior chamber iris fixated intraocular lens placed. It appears to be well enclaved, holding its enclavations on both the sides, and there is a peripheral iridectomy based on the edges, probably surgical, given the smooth edges, to avoid post-operative sequelae of pupillary block glaucoma. And other than that, I can't comment on the lens. I mean, probably the patient has uh, this as a secondary IOL implantation.
All right. How will you like to, what other examination would you like to do for the patient?
I'd also like to assess the patient's posterior segment and see whether there are any complications which may be in this scenario related to posterior capsular rent, and then a secondary IOL placement which is suggestive of vitreous loss, and therefore peripheral breaks have to be definitely screened in these patients. I'd also like to see the disc health, the macular health in general as a part of routine evaluation. And yeah, periphery examination with indentation is, I think, has to be emphasized here.
All right. So what are the indications for this procedure?
Secondary iris claw implantation, IOL implantation can be done in scenarios where there is a lack of sulcus support, in a case of posterior capsular rent, or in cases of zone neurodialysis and ectopia lentis, or in cases of the cases where there is zonodialysis secondary to acquired causes like hypermature cataract and Morganian cataract, posterior pseudoexfoliation syndrome, or in cases of congenital cases where if it's very severe, as in Marfan syndrome or homocystinuria. Mainly, it is usually done in scenarios where there is posterior capsular rent and there is no sulcus support with good, adequate, healthy iris for implantation. Sulcus sterile fixated IOLs can be a very good alternative when there is a lack of healthy iris to support the IOL.
What are the contraindications for this procedure?
Iris claw, especially anteriorly placed iris claw, should not be done in scenarios where there is poor endothelial health, because it is associated with endothelial decompensation significantly. It should also be avoided in cases where you are suspecting uveitis like Fuchs heterochromic iridocyclitis. You may unnecessarily trigger more inflammation, and in cases where the patient is a glaucoma suspect, it should again be avoided, because again, UGH syndrome has to be considered. Pupillary block has to be considered. So for those reasons.
What are the complications that can happen with this procedure?
Again, I feel endothelial decompensation leading to pseudophakic bullous keratopathy, early postoperative phase and late postoperative phase. In early postoperative phase, there can be suture site leaks because of the section not being formed properly, or there can be the iris claw losing its enclavation and getting loose, and patient having diplopia glare for minor symptoms, or poor vision because of it not being fixated as a major complication. And it can also have uveitis in the early postoperative phase, pupillary block glaucoma if PI is blocked or PI is not done, and uHfIap can occur because of iris tissue being damaged. Late postoperative complications can be endothelial decompensation, glaucoma progression, and I think that's all I can think of.
All right, that's great, Arhan. Yep, that was again a very well structured answer. So I think the only place where I would reduce point is when asked for what other examination. I think you did not mention about the vision and intraocular pressure. I know you
Sorry.
mentioned the complications of glaucoma, but yes, so you need to
Okay.
mention that. Yes.
Understood.
Then, yeah, other than that, one other complication in these procedures is you need to tell the patient, aesthetically, we need to tell the patient that they can have a change in the pupil shape and size. It's in brown eyes, we don't notice much over there, but here with the different color irises, it's very obvious. So, and they are very particular about that. So we do have to mention that before the procedure. Yep. I think otherwise you did cover most of it. Any other points from yourself, Sweta?
I agree with everything. The only 2 points extra I've noted is to say no vitreous in AC. When you examine there in the picture, it's obviously not possible
Yes.
to comment, but when you examine, you need to make sure to tell that there's no vitreous in AC. You're looking for it. You mentioned this is just nitpicking, not a very necessary thing, but you said secondary IOL. So it could also, here they do it primary
Primary.
procedure. They have a
Okay.
data. So just say primary or secondary. Like I said, it's nitpicking, but have it in the back of your mind. And the most commonly used thing is they call it artisan IOL. So know the name. If the examiner tells you this is an artisan lens and go on, don't be shocked. It's called artisan. I did not know when I came here. It was very new word to me. So we put it up on the slide. Know 1 or 2 names for this. That's all. These are the 3 points I've noted. And I wrote pigment dispersion can be added. You said UGH, pseudo exfoliation, Fuchs heterochromis. Just add pigment dispersion to the list. That's all. Otherwise, perfect pass.
Thank you. Thank you so much, ma'am.
So next we have Shastika. So we'll go on to the next one.
Otherwise, it's Shastika next and next Merin.
Merin, yeah. All right, Shastika, could you tell me the clinical findings for this patient?
This is the photograph demonstrating anti-segment image where eyelid, the upper eyelid is seen. It is normal. Conjunctiva is clear, and there is mild temporal congestion. And cornea, it is a bit hazy, inferior. I mean nasally and inferiorly. And iris, 6 o'clock to 12 o'clock iris is there, and there is an absent of iris from 12 o'clock to 6 o'clock position. This is and lens is clear. My top differential diagnosis would be a partial aniridia or a surgically induced iododialysis or traumatic iododialysis or and that's all my top differential diagnosis. And I'll start with the history taking, and I will
Okay,
examine the eye.
Yeah. So, what would you like to get in history and other examination for this patient? Considering this is a pediatric patient.
I'll start with history taking, whether the patient had any congenital anomalies associated systemic illness. Then I will also examine for the other eye. We'll look whether the other eye irises are having a similar pattern, or we'll examine the posterior segment also in both the eyes, or whether the patient has undergone any recent history of surgeries. And we'll check intraocular pressure to rule the associated glaucoma in case of aniridia, and whether the patient is also having any associated systemic anomalies. And we'll also advise the patient to get an renal systemic examination to rule out Wills tumor.
Any other
Then
examination of the eyes?
we'll check the posterior segment. We'll check the fundus. We'll look for any retinal or choroidal anomalies. Then we'll check angles. We'll do a gonioscopy and check the angles. My management depends upon the it depends upon the intraocular pressure and depends upon gonioscopy. If it is since it is a pediatric patient, my top differential diagnosis would be Wagner or Chart syndromes. Will rule out will liaise with general physician and pediatrician. Will do a multidisciplinary approach for this child. My management
All
will
right.
be competitive, like
So, what would be the
planning
sorry, Shashtika. So, what would be the complications that you can expect in this child, and how will you manage that?
okay, complications will be congenital glaucoma or congenital glaucoma, and if the um, for congenital glaucoma, we'll start with a topical AGM based upon the IOP, and we'll do it. We'll liaise with glaucoma team, and we'll advise for trab on trab. Goniotomy. If the since the cornea is clear, can do a goniotomy. If the cornea is haze, will can do a trabeculotomy with trabeculectomy.
All right, that's okay. You did well, Shastika. I'm not sure if the image is not very clear. There is a bit of some cataract there, like a posterior component, but I will let it be. It looks like a reflex also, so let's not go there. But yes, this is like a congenital aniridia. You did mention the findings and everything. But when you mentioned the hazy cornea, I'm not sure. Did you mention the limbal stem cell deficiency? I
No, I
don't
didn't.
know.
I
So
didn't.
that's one thing. And I think I had to prompt you for the further examinations in terms of other anomalies in the eye, the gonioscopy. So you did mention that you'll check for the other retinal and choroidal ones, but that just without the prompting, that would be a bit more better. And again, further in terms of examination, you need to do the investigations of optic nerve head imaging, OCT, visual field analysis, and all those. And definitely you mentioned Wilms tumor, which is life threatening. That's very important, and multidisciplinary approach. So that was good. And treatment wise, again glaucoma, but since you did not mention the limbal stem cell, I think you did not mention about that. But again, these children are prone for cataracts, so that management needs to be sorted out as well. And there will also be management of the glare because of the aniridia. So, and cosmetic management if needed, along with the cataract management. I think that's from me. Anything else from you, Sweta?
I've also just noted that when points for mentioning the anomalies and Wilms tumor. I passed you in the station, but avoid using abbreviations like AGM. People in the exam or in the UK will not understand. Anti-glaucoma medication, you have to say, just say glaucoma drops there. Don't use unofficial abbreviations. And she had to prompt you for coloboma. So just have all these quickly. Charge and Wagner, it has to come immediately. One point that I don't know how important it is, but I was asked about this in the exam. When it is said it is a pediatric patient, I would think it's always wise to say you need examination under anesthesia, because you will not be able to do gonioscopy or anything in on the slit lamp for such patients. They'll already have so much glare. They could be amblyopic. They will not be able to fix. Nystagmus is a possibility. So try, and when they say it's a pediatric patient, put examination under anesthesia as in your management as one of the points. That's one feedback I wanted to give. Otherwise, the stepwise approach was okay. And be more confident. You know all the points, but you are stopping everywhere. Just improve the flow. Otherwise, the points were okay.
So every time it's like the protocol here is every time there is a prompt, they reduce mark. Even if you told everything after that, prompt means 1 mark less. So that's a bit tricky, but that's how they mark you. All right. So I think we're going with Merin for the next one. All right. I'll start the timer. All right, Merin, go ahead and explain the clinical picture for me, please.
This is a clinical photograph of the right eye and adnexa. The upper lid shows congestion with a raised area, a mass at the involving the upper lid margin at the midline, along with loss of architecture of the lid margin and loss of lashes and trypsiasis. There is mild upper lid edema as well. The anterior segment and the lower lid appears normal.
Anything else in
my
the examination you'd like to add? Any positive, negative findings?
there is skin excoriation as well as loss of architecture of the lid margin, loss of lashes, and also telangiectasia over the mask.
All right. And what other history or examination would you like to get from this patient?
I would like to get the duration of the lesion and
Treat it as any mass. So history-wise, onset, gone. It's the same thing.
yeah, onset, duration, associated symptoms like pain, recurrence, and any systemic associations which can indicate immunosuppression, any history of trauma, any history of previous treatment done.
And examination.
I would like to do evaluation of the lid assessment by seeing if any toss is there, the action of the levator palpebrae superioris, if there is any deep, to see if there is any deep infiltration. The I would like to invert the lid and see the extent of the lesion. And I would like to examine the local lymph nodes also to see if there is any extension.
All right. How would you like to manage this patient?
So after systemic evaluation, I would like to go ahead with an excisional biopsy of the lesion with lid reconstruction, either at the same sitting or based on the extent of the lid defect. And on the same sitting, I can do a frozen biopsy before the reconstruction of a mouse procedure, and I can do a definitive pathological assessment later.
So what would be your top differentials for this patient?
A basal cell carcinoma, squamous cell carcinoma, or a sebaceous carcinoma, sebaceous gland carcinoma, because I can see few yellow deposits also on the lesion. So that can be fat deposits also. So my top differences would be any lid malignancy.
All right. Any other questions from you, Shweta?
This can also be an infectious pathology based on the duration of the lesion.
Yes.
All right. So that was a good attempt, Merin. So I think the initial like positive negative findings, you need a bit of a prompt, because especially you added the telangiectasia and the ulceration and everything after the prompt. So always positive and negative findings, have a list of them, especially for lid tumors, whether it's present or not, you need to tell them, because that in that way your differentials are in order. So you need to have like a benign as well as a malignant differentials. But this was, since you said about the telangiectasia and the ulceration, yes, you can directly hop on into the malignant differentials, that is more obvious. Then I think even with the history, you need a bit of prompt, but you again missed asking about the risk factors like sun exposure, any other similar skin lesions anywhere in the body which was treated priorly, any history of any radiation therapy and all that. And again about the recurrent chalazions, infections in the eyelid. Some of the points that I know it can, when we are suddenly thrown into it, it doesn't come into you, but a lid lesion, just have these, like what do you ask in terms of high history and systemic history, and like sun exposure is very important over here. Yeah, I think those were the two things, but otherwise management wise you were pretty much aware of what you needed to do. And this is a small one, so 20, you did tell about the 25% closure, if I'm correct. If it's a bigger one, then you would need to also elaborate more on the other managements.
Yeah. I think the second part she was bang on. The first part
Yeah.
is the examination part, most important, vision, refraction, IOP. Don't forget, it's still, you have to tell that. because lid pressing on the cornea causing astigmatism.
Astigmatism.
They will just nitpick on you on that. So don't give any chance to reduce mark, because the latter part you did very well. So the first, just quickly go with the flow. Have a list ready for benign versus malignant and upper lid versus lower lid. That is very important in this station. If they show you a upper lid mass, say squamous more than basal cell, more than sebaceous. If they show a lower lid mass, say because of the location, I will go with basal cell versus squamous cell. So just be very vocal about your differential in that, so they know that you know. Like I said, UK exams is not about your knowledge, it's showing how much you know and how you put it in words. So be vocal about it. And like tell about systemic associations. Any lid mass, treat it as a cancer in your exam and use the word. Again, I will coalesce or liaise with my oculoplasty team. I will rule out any other systemic associations. It will be a multisystemic approach. And here, specifically, all these Mohs technique is not done by the ophthalmologist or the plasty team. It's done by the dermatologist. Yes, it is shocking. So you have to say, in case I need to do a Mohs technique, I will also liaise with the dermatology team, my oculoplasty team, and I will make a treatment plan based on what is required for the patient. So use these terms that you will liaise with various departments. You will earn a mark there. And any station, just have one line that you will say, I will quickly check for vision refraction. I will do a complete examination of the anterior and posterior segment, and I will proceed with. So in 10 seconds, you have told everything. So you will not waste time and you will still have time to talk about your management. This is my feedback. And she told lymph node examination. So second,
Yes, that's
it's
point on.
just the first one, I reduced 2 marks. It's one.
Mhm.
You will still
Yeah.
pass this station, but there is scope to get full marks.
All right. I think we'll go back to Bina again. Is that all right?
And anybody
Yes.
wants to volunteer, please raise your
Anyone
hand.
else or
It's not
Bina?
like you're not welcome, but Bina's already volunteered, so we'll go back to her.
Yes. Okay. So
Yeah, we have more hands coming up now.
all right, perfect. Okay. So we'll start with Bina for this one.
Yeah.
Can we play the video?
Yes,
Sita?
sorry.
I'll start the
Yeah,
timer once the video
we'll do.
starts. Yes.
Yes.
Bina, you can explain as the video plays, or you can
Okay.
explain after the video plays, whichever is comfortable for you.
So
Okay.
I
So
play
this
it
is the
twice,
okay.
just like in the
So
exam.
So this is the facial video of the person focused on both eyes. This is looking for the pupil examination. We can see there is anisocoria in the dark more than in the light. The right eye pupil is not dilating as well as the left eye, and there is a constricted pupil in the right eye, which is an abnormal pupil, which as it is not dilating in the dark. There is a small amount of ptosis in the right eye as well. Um, the and so so meiosis, ptosis. The other features I can see is there is prominent anisocoria in the dark. The blink reflex is present in both eyes. So the video has stopped. So my top differential in this case is right Horner syndrome. Um, wi- uh, with pupil abnormality, and the other there is no heterochromia in this case. I could not comment on anhydrosis. So I'm pretty sure this is a case of right Horner syndrome.
Okay, how would you like to proceed?
So Horner syndrome I would consider as an emergency once I have confirmed the clinical features in the clinic. I would quickly take the history of the patient about how about the symptoms. Did it start acutely? Did he have develop any pain behind the eye? When did he notice the ptosis? And what do they have any other health problems? Did they experience any pain in acute pain in the neck, or did they undergo any recent surgery for the thyroid gland, any neck surgeries, parotid gland surgery, or any do they have any other respiratory conditions on the same site? um, and are there any hypertensive patient, diabetic? So I will briefly take this history. I will do the visual assessment, look the pupil abnormality. I will note, do the anterior segment, posterior segment evaluation, and I will immediately liaise with my medical um, emergency team for further investigation of the patient, and they possibly will need urgent CT angiography of head, neck, and thorax to confirm any other pathologies causing this condition. So for
Any
this, they may need to be
other test
admitted to
you
the
do?
medical ward.
Yeah. Any clinical test would you want to confirm your diagnosis
Yes,
at the clinic?
to confirm the pupillary abnormality, I would like to do apraclonidine test, in which I will put a drop of apraclonidine 1% or 0.5% in both eyes, wait for 45 minutes, and once the and look for a pupillary dilatation. So if it is a Horner syndrome, the patient's pupil on the affected side will dilate more than the normal eye, and also the ptosis will seem to be resolved. So that would confirm the diagnosis of Horner's. The other tests which are not done currently are the cocaine uh, drop test.
Okay, that's fine. That's fine. I think the time is up, but you covered most of the points, and all points were covered. Just mention RAPD alone, but everything else is fine.
Thank
And
you.
like you rightly said, in the clinic, we would just do the apraclonidine test. We would not do the other tests in the UK. You don't have to worry about telling this cocaine test or the other tests given in the textbook. Though they might not mark you down, there were instances in the past where the examiner said this is not done clinically. Why would you tell that and waste time? So to be on the safer side, just say in the clinic we use the apraclonidine test. But there are other tests like the cocaine test or hydroxyamphetamine, which helps us to differentiate between first order, second order, and third order. But because it's a medical emergency, you mentioned CT angiography. You're not wrong there, but the recommendation is MRI with an MRA. But like you rightly said, you can just add imaging CT or MRI with angiography and say head, neck, and thorax, just like you said. And the video was of an adult, so it's fine. In children, the emergency is to rule out neuroblastoma. Okay.
Yes, thank
But
you.
otherwise, the points what she covered were exactly the same. And one additional suggestion here is add a differential. You were right on the diagnosis of Horner's. They will not mark you down. But if they ask what are the differentials,
Yes.
just have a list. We didn't ask you, so it's fine. I'm just telling you as a feedback, just have a list of diagnosis for that.
So just if I say that maybe a congenital ptosis or
Mhm.
some residual ptosis following correction.
No,
Um,
you have to give diagnosis differentials for the pupil. So go more like tonic pupil, pharmacological dilation,
yes.
something
Tonic
like
pupil.
that, rather than on the ptosis. So the differential you will have is for that tonic pupil or Turner palsy or
Okay.
this pharmacological dilatation. So have that list in your hand. And you say my top differential is Horner's because in dim illumination there was anisocoria. And easy way to put across what you said and still have more time is say on 1% or 0.5% apraclonidine, I will say reversal of anisocoria. That's an easier way.
Okay.
This is
Okay.
nitpicking, but you definitely passed the station. Well done.
Thank you very much.
I think we had another hand up now. I didn't see the
It
up. It was
it
some
was Dr.
Bushra, no? Bushra.
If they're interested, they can do it. If not, we will go ahead with Merin, whichever.
Hi, Bushra. Are you still
Hi.
there?
Yeah, I'm here.
Okay.
I'm not well prepared, but I can try.
Sorry, just go ahead
Fine.
and give it a shot.
I think the entire the cohort here is not prepared. They're just starting the preparation. This is just to give an idea as to how to prepare. So it's fine if you are blank. Just describe and try.
Okay.
All right, Bushra, we'll start playing the video.
Okay.
Shweta,
This
can
week
you play the video?
I can see the face of the lady,
Mm-hmm.
this lady with There are left eye mitosis. And on eye movements, there is limitation of adduction in the right eye and limitation of adduction in the right eye. Sorry, yeah, left eye. And on elevation, there is. So can I?
Yeah, I'll play it thrice because it's a very short video.
Left
Go on.
diagnosis and yeah, limitation of adduction in the right eye, limitation of adduction in the left eye, and on elevation there is a limited elevation. Mm,
I will give you a prompt. When you're looking of the A reduction in the right eye, can you look at something in the left eye? Same way, vice versa.
Is that saccadic nystagmus?
Yes, yeah, you're getting there.
You're getting there, yes. We're just prompting you because we just want to get you into so that you can answer more
Yeah.
questions.
So there is
So,
limitation in
yes.
in both eyes
Mm-hmm.
with abduction nystagmus
Yes.
in the other eye.
Yep, perfect. So what would be your differential or your top differential?
The bilateral internuclear ophthalmoplegia. I know.
All right, that's perfect. So how would you, what other examination would you like to do for this patient? History and examination, please.
So I would like to ask in history about any symptoms of diplopia or limitation of visual field, and that can cause the limitation in day-to-day activities, or if they are driving, I would like to address driving as well. And is it getting worse? And when I would like to about onset. Was it after any history of trauma? Or then is it getting worse over the time? And other thing is any history of diabetes, high blood pressure. That's what in history. I would like to examine visual acuity, pupil examination, and intraocular pressure. I mean, I will complete my anterior and posterior segment examination, and I would like to check disc as well, and for haze chart and visual field examination. And yes, I would like to go for investigation, mainly MRI, brain, to route multiple sclerosis or underlying pathology affecting, yeah. And I would like to ask about any systemic symptoms, any what is it called, weakness in limbs, or and for regarding management, I would like to liaise with the neuro-ophthalmology team and orthoptist. I'm not sure about. And based on the investigation, we need to treat underlying cause.
So ocular management, you said you liaise with the orthoptist, and what would we be doing after that?
So
What are the managements? Yeah, just to prompt.
yeah, patient has limitation in adduction, so that can cause diplopia. So we can offer. I'm not sure about prism, but prism can be tried. I don't know.
All right, that's a good, really good attempt actually. Thank you so much for doing that. So I know we did a bit of a prompting. So always with videos, you will have a mixed hybrid exam. So videos you can go back. So when you're looking at one eye at the first time, try to look at the other eye when you're looking at the video the second time. And so we were able to get into the ipsilateral abduction deficit, yes, and the contralateral abducting nystagmus. So it is, but then first thing is always comment on the position of the eyes. So there is an obvious exo deviation. So exotropia could have been commented. And then coming to the movements, as you can see, adduction deficit and abduction nystagmus. So that was the main two things that would take you towards a diagnosis. Always with movements issue with the eye extraocular movements, one differential that you can offer is myasthenia for any sort of differential that you can go ahead. But this was a very obvious one, so there won't be any points reduction, so don't worry about that. Any neuro-ophthal case examination, always bring in color vision. I wanted to even comment that before. Any, GCA and all that, always mention about color vision, please. So management wise, yes, based on what you're finding, so you need to go into investigations, you look into all these causes. So this is something you'll come across more often in the OSCE part of it. So all the causes of the reason behind the webinar could be anything. It could be infection, inflammation, trauma, tumor, could be congenital, could be a demyelination. So you need to find that out. And any strabismus management is going to be, first would be a conservative management, and then it would be surgical management. You start off first with patching. If there is obvious diplopia, then refer to the orthoptist. They will check for prisms. If possible to correct with prisms, they will do that. If not, then they'll refer back to the strabismus specialist, and they will look for temporary ones in terms of botulinum injection, or if it's a long-standing one, then they would think about surgical correction. So that protocol, I think, is going to be the set protocol for any strabismus procedure for you. But you did correctly say about treat the underlying cause. That's a very important one, because without treating that, you do not go into any permanent correction of the eye alignment. Anything else, Sweta, from your side?
No, I think once prompted, her diagnosis was spot on. And I also did write myasthenia, because that's like a differential for everything in all neuro-ophthalmic cases as far as exam is concerned. Just have it like that. And for the causes, this is a set list whenever you have any neuro-ophthal case in the exam. Start with infection, inflammation, demyelination, stroke, tumor. So these 5 things that you have to have in the list, and just tell it in order. And depending on the age of the patient, I will go, if the examiner tells you this is a young female or something, say I will rule out demyelination, about the inflammation and infection, then rule out space occupying lesions. And always in neuro-ophthalmology, say I will examine other cranial nerves as well, make sure they're not having a stroke. And like she rightly pointed out, vision and color vision, have it as a template. Again, have this as point 1, 2, 3 as a template, so you're not fumbling in the exam. Just tell it out, and you have a lot of time to think about the case and the video rather than concentrating on these points. So again, practice will really help to make lists. And as the minute we say, how are you going to manage the patient? Say, I'm going to liaise with a neuro-ophthalmologist, strabismologist, orthoptist, patching, prism as the conservative management. Just tell it for all the cases. That will really help you.
Yes. But that was a really good attempt. Thank you for attempting
Well
that.
done, Bushra. You attempted it really well.
Thank you.
So I think we have Merin again on the list. Yes, let's
Yes, I think
go for the next.
and then we have
Ahan,
Ahan and Shashtika.
Ayman and Shastika, yes. All
One
right.
second. Dr. Ayman, if you can speak, is it all right for the neuro-ophthalmology? Would you have any more
yes.
points to add on neuro-ophthalmology?
Actually, you have covered everything. I just want to add that most probably in bilateral INO, I think it could be a good point to mention that bilateral INO goes more with demyelination rather than ischemia.
Okay.
However, in monocular, it's more common to be ischemic or compressive lesions.
Okay.
Yeah.
Thank you. It's good that we have a neuro-ophthalmologist so we can get our corrections as well. So yes, thank you, Ayman. Thank you.
Thank you.
All right, I think next is Merin on the list.
This is the external photograph of the face, and the eye showing the most obvious feature is both eyes lid retraction with the superior and inferior sclera show. The conjunctiva appears congested. There is proptosis of both the eyes. The anterior segment of the eye from the cornea, pupils, and the iris appears normal. Uh, about the face, I'm not sure. Is it congested or is it normal?
Whatever
that-
you're seeing, you can comment. Yes,
Yeah,
please.
yeah.
The facial skin also appears congested. So, my top differential based on this clinical findings would be thyroid orbitopathy.
Okay. How would you like to proceed with history and examination?
So, I would like to ask about any recent diminution of vision, any diplopia, uh, signs of dry eye, like increase dryness, stinginess, especially in the morning, uh, watering and photophobia. Also, systemic symptoms of thyroid toxicosis and hypothyroidism, like fluctuations in weight, tachycardia, any
Mhm.
tremors, any lesions on the leg, and any weight gain, hair loss, and any constipation or loose stools, gastrointestinal symptoms, any other cardiovascular or neurological consultations for any cardiovascular neurological problems.
Mhm.
Also, I would like to ask if the patient is already on treatment for thyroid disease, thyroid dysfunction, already tested, or any oral medications or any radiation has been or surgery has been done for the thyroid issue.
Mhm.
So the examination would be, I would like to check the visual acuity, the color vision, extraocular movements, um, and the dry eye test like Shermer's test and T-BUT, and the tear film height. Also the lid evaluation for the lid signs of thyroid eye disease, like lid lag on down gaze
Mhm.
and congestion and extraocular movements. Also, I would like to evaluate for the proptosis, the amount of proptosis by an exophthalmometer. Any changes in the proptosis on valsalva or position to rule out other causes. Also, I would like to examine the fundus to see for any compressive orbitopathy. I would like to look for disc edema, posterior compressive findings like choroidal folds,
Mhm.
or absence of spontaneous venous pulsation if it's already recorded. Also, I would like to ask the patient about other histories of recent history of trauma or
Mhm.
tinnitus to rule out the rare possibility of cavernous sinus thrombosis. About
Any
the,
other grading that you would like to do?
I would like to do a visa scoring where the vision, the inflammation, the strabismus, and the appearance are recorded. The on
Okay.
the first on the and also the clinical activity score. If it's a first presentation, I would grade the thyroid orbitopathy out of 7, and if it's repeated examinations, I would like to score it on 10 to see the changes in increase in diplopia, vision, and increase in restriction.
Okay. Say if this is a moderate to severe thyroid orbitopathy, how will you proceed with the management?
So first, I would give supportive treatment for dry eye disease in all grades of thyroid orbitopathy, like
Mhm.
um, lubricants, lubricants, and also lid taping if necessary if the proptosis is severe. Also, in cases of moderate to severe thyroid orbitopathy, I would first control the thyroid condition with the help of an endocrinologist.
Mhm.
Also, the treatment would be pulse therapy of intravenous methylprednisolone in association with oculoplastic colic.
Okay.
After if it's sight-threatening in severe cases, like if there is any corneal exposure keratopathy, or any compressive optic nerve compression, I would like to go ahead with the orbital decompression after referring it to my oculoplastic colleague.
Are you aware of any guidances for this? For the severity of disease, are you aware of any guidance that we would use and when we would treat?
The uGogo classification gives the guidance for mild disease and moderate and severe disease. So in mild disease, it's mainly supportive treatment and control of the systemic condition. In moderate disease, again, supportive treatment and control of systemic condition along with intravenous methylprednisolone. And in severe sight-threatening disease, I would like to go for intravenous methylprednisolone. And after assessment of the effect, I would, if necessary, I would go ahead with the orbital decompression, which
Okay,
would be 1 volt, 2 volt, or 3 volt based on the severity of the proptosis.
excellent. Are you aware of Rundle's curve?
Yes, Rundle's curve. Rundle's curve notes the natural course of the disease, which starts as active disease, which usually lasts for 6 months, followed by the quiescent phase or inactive phase, which would last for from 6 months to 12 months up to 24 months. So Rundle's curve notes the natural course of the thyroid orbitopathy.
I think you did well there. The
So
only
can I
feedback,
ask about the congestion? What is with the congestion of the face? Is it normal in Europeans, or why is the face so
So
congested?
that's a good question, because but you can't expect erythema of the eyelid in thyroid eye disease. So could be that. But sometimes patients do come if it's very hot climate and everything. They do come a bit
if it's a bit
flushed.
pink and they
Yeah.
are flushed. So
Yeah.
I mean,
But then you can
have-
still comment erythema of the eyelid with TED. So you're well within your rights. Yeah.
the one feedback I would say is right away go with saying I will do the clinical class. When we ask the question, say in history, I will ask this. Your history and examination was fine. The feedback that I have written here is investigation wise, I will ask for thyroid function tests, CT scan and MRI. I think they ask for T2 STIR protocol here. So that one. I will also ask for Hess chart for the orthoptic review in case of if there is a lot of movement restriction. So that's the feedback I've returned for the investigation part. But others you covered well. You spoke about corneal sensation and cornea and all that. That's okay. And in management, straight away say I will check the clinical activity score and classify the disease according to the uGogo guidelines and depending upon the severity. So that was a prompt. So that's where I've reduced 1 mark. So without a prompt itself, directly say you told the content, but actually put it together and say I will classify and I will also plot the Rundle's curve to know in which phase of disease the patient is in. So that's a concise, comprehensive answer where they cannot reduce marks. Anything else?
Yeah, I think as Ahan has pointed out, erythema of face could be related to thyrotoxicosis and can be linked to urgent treatment. Yes, that's a good point, Ahan. Yes, we can always mention that any finding that you see in a photo or clinically in a patient, you can always link it to the condition that you're trying to do. They just want you to be a safe doctor. So you can be wrong, but it's nothing, wrong in pointing it out as well. Yeah.
No, that's fine. So yeah, the concise answer or the template that you use would be to say clinical activity score according to the uGogo. I'm going to start this. So I asked you if it's a moderate to severe disease, what are you going to do? My expectation was to say IV methylprednisolone gram every day for 3 days with a maximum of 8. So few doses are important. One is in ONTT for optic neuritis, one is in thyroid, and one is in GCA. So these 3 things, memorize the steroid dose and the regimen for that. That's the only feedback, but I think you'll pass this station.
So we have Merin next for the next station.
Oh, Merin just did this station.
Oh,
Next
she
is-
did. All right. Okay. So then it is Ahan then again.
I think that's a video again.
Okay. This is a video showing the external examination of patient done in the presence of patient fixing probably a patient's eyeball positions and primary gaze with the glasses on are appearing to be orthotropic. However, on removing glasses, there is deviation noted, particularly in the right eye, probably suggestive of refractive accommodative esotropia. And I'd like to evaluate the patient's examination with a series of tests, including first sensor test related to stereopsis, Watts 4-dot test, and Titmus fly-based stereopsis test, so that the patient's fusion is not broken first. And once sensory tests are done, I like to proceed with motor tests, mainly cover tests and cover tests, and also try to determine whether there is any whether it is incomitant or comitant by checking for primary and secondary deviations.
All right. You mentioned about the examination. How would you can already see that there is some management, but how would
Yeah.
you further classify this patient and manage them?
This is probably refractive accommodative esotropia, but we can also check for the deviation and on distance and near, and based on that see whether it is a partial refractive accommodative esotropia, or it is having a non-refractive component in terms of persisting near deviation, which may require executive bifocal glasses bisecting the pupils. And of course, I'd like to mention that I'd also like to assess the patient's vision, refraction, intraocular pressure, and a comprehensive anterior and posterior segment examination for a thorough evaluation.
All right. So you did mention a bit of about the management, but can you elaborate more? What are the other modes of management?
Yes. So accommodative esotropia can be managed by refractive correction usually, especially for the refractive component. Partially refractive errors with persisting near deviation can be treated with bifocals, and there is also a role of prisms, orthoptic devices, and even dichoptic therapy recently for treating amblyopia, if any. And of course, we should screen for amblyopia in all cases of squint, given the prime age of less than 7 years, where the patients are usually prone to develop it, with specific test, vision based, whether there is crowding of letters, and all the other phenomena.
Could you comment a bit about the surgical management for this condition?
Yes. So if the patient has accommodative esotropia which is not getting fully corrected, we can go for, in this scenario, if the patient has a very good vision in the right eye, which is usually expected, we can go for bilateral procedures. So bilateral medial rectus recession can be something that can be done based on the amount of deviation. However, if the right eye is having amblyopia, then a unilateral approach can also be preferred for the right eye. And that the patient always has to be explained about the consent for the procedures, the chances of having overcorrections, undercorrections, and need for further treatment, constant follow-up to check for vision, and even amblyopia therapy if needed later on. So all of these things have to be counseled to the patient preoperatively. And I like to have a good anesthetic fitness being obtained for the patient, because the patient may require general anesthesia given the patient's age.
All right. Thank you, Ahan. That was you did well in terms of identifying the clinical features and what was the finding there. That was
Mhm.
good. I think you mentioned amblyopia, but that was a bit later, wasn't it? Not initially in the examination. Yes, so I mean it's good, but you did come back around to it without the prompt. But ideally, any kid with any type of strabismus or refractive error, it's mentioned about amblyopia, and you will treat the amblyopia before anything else because that's of high importance
Yeah.
as well. And did you mention about the patterns of deviation when you for examination? Anything about patterns?
No,
No, I
No,
don't think so. That wasn't. So
that's
it's
the
important. Yes.
A pattern, B pattern to mention.
understood.
Pattern deviation is important. And also, I'm not sure how important this point is for the accommodative esotropia. We always talk about the ACs to A ratio. So just mention that needs to be evaluated as well. I think that's part of it. And surgical management, it needs to be prompted a bit. So automatically management wise conservative. You can
By
botulinum injection and surgery, as we mentioned, that needs to be a part of it. And if we talked about the patterns, then automatically, I think you would have also need to speak that if it's more deviation in near or distance, based on that, which muscle is involved, that's something that, if it's more for near, then it's medial rectus, more for distance, it's lateral rectus. Same way, if patterns are involved, then you will transpose along with the, recession. So I think these could be just brownie points, but still it's better to add them into your management options. Anything else, Vita?
No, I've written pattern AC by A ratio and in
Mhm.
management to classify as surgical.
All right. Yeah.
So these three things will just have make your answer look very, very organized, and then they will not reduce mark. Even if one examiner nitpicks and reduces, the other will quickly mark you.
Okay, thank you so much.
Perfect. So, who are we? I think next is Shastika. What do we have next station? I think we have two more retina left. Yeah. All right, Shastika, can you describe the clinical picture one by one, each image, what it is and what is the finding?
Yes. This is the color for the first image. A is the color fundus photograph, which is a wide field of photograph. Starting from disc cup disc ratio is normal, AV ratio is normal. I could see a black pigmented deposit of almost a 4 disc diopter superior to the disc, and it is also having hypopigmented pigments which is present. In image B, I could see it is a red-free photo. And image C is a OCT of the same fundus, where there is a marked elevation of the RP is noted, and there is also a mild subretinal fluid present. Multiple subretinal fluids are present in OCT. So, owing to the top differential diagnosis would be a choroidal melanoma.
What are the differential? Could it be anything else?
Choroidal nevus. First, starting with choroidal nevus, then choroidal melanoma, choroidal hemangioma, or it could even be a retinoblastoma. I would like to proceed with the B scan and take a history of the patient and also examine the other eye fundus and the age of the patient. And since my top differential diagnosis is choroidal nevus, I should do a moles staging. If it is more than 2, I will do an urgent referral. If the scoring is 1, I will look whether the thickness is more than 2 mm. And since there is also subretinal fluid, and there's also
So-
orange pigment.
What would be your mole scoring for this patient?
It would be more than 2.
Could you comment on how you got to that?
But I would like to do a B scan. I would also look for reflectivity, whether it is highly reflective or it is low reflective. because the
Mhm.
thickness is more than 2, and there
How
is
would
a
you measure the thickness? Could you elaborate how you measure the thickness?
in OCT I should measure from the apex to the base.
Mhm.
So the OCT image is here.
Yeah.
And if in B scan, it should be mushroom shape. Then there's orange pigment and it is large. And enlargement should be more than 2 mm thickness. Then S is subretinal fluid. There's also subretinal fluid present in the OCT.
All right. So,
So,
you said you would refer them. What is, where would you refer the patient?
if the patient is from England, I would refer to London, Sheffield, and Liverpool. If the patient is from Scotland, I would refer to Glasgow. And I liaise with the pediatric and oncology team for further management.
All right.
So send the patient to gastroenterology to rule out familial adenomatous polymosis and Charcot syndrome.
What would be the correlation for that?
There's a high chance of FAP for the patients with choroidal nevus.
All right, that's okay. So that was a good one. Your description was very elaborate. You had the size, shape, the description of the lesion. But Mole's criteria, it's before you tell the scoring, don't just say more than 2. Give a definite scoring on how you came to it. So I think for that we need to just know what each one is. So if say the size is more than 4 disc diameter, then it is scored 2 for the size. If it's subretinal fluid is there, it is 1 or 2 depending on OCT or without OCT. Same way, whether orange pigment is present or not. So when if you give it that way, instead of just saying more than 2, if you say 4, 5, and why I came about it with the score, then it will be more clear. Differential, yes, your top differential was good based on the moles criteria, but always try to give a differential as well, like hemangioma, melanoma, osteomas, nevus. It could be anything. We don't know about it. And tumor pathway wise, you said we have to immediately refer to these are the centers. It's very important that we know the centers. There are only few centers, and patient will ask you where exactly you're sending them, and depending on which is more easier for them, they would prefer to go there. B scan wise, yes, you were spot on with what you're looking for in the B scan. That's good. But I think other than that, I'm okay with the description. Anything else, Sweta?
No, I think the same points I had written. I just wanted at least if you don't remember the exact scoring, just say mushroom shape, orange pigment, large size, enlargement, and subretinal fluid. And based on the grading, you can be vocal and say, I can't recall the exact thing, but this is definitely more. I would quickly seek the help, pull up from the intranet and do the scoring. You can say practically
Yeah,
what
you can actually. Every time that's what we do.
I mean, I said so in the exam
Yeah,
because
yeah.
I didn't remember the exact 0, 1, 2 for each thing. In the stress of the exam, it is not possible for everybody to recall unless you've like specifically revised that. So it's normal to forget it. If you forget, just say quickly, I will quickly pull the criteria up from the intranet or internet. I will do it. If the score is this, I will do this. For this, I feel because of the shape, orange pigment, and size, it would definitely be more, and I would err on this side. So be vocal. If you forget, don't blank out. It's fine to forget, but just show them that you are safe and what step you will do next. That itself will earn you a pass easily.
Yes, so that's the thing because
The second image, it was fundus autofluorescence, right? Not infrared.
yes, it's autofluorescence. It's not red free. Yes. Good one. So that's the main thing. Otherwise, this is another very common thing you'll come across in a practice in UK. So it's mandatory that you know about this. They will expect you to know about this. Yeah, it's
And
part of your communication station as well. I think this
yes,
one.
yes. I'm not sure about the familial FAP
Mm.
polynosis. I will look it up, but
No,
you
that
might.
is for chirpy. So good thing you told
Uh,
that. So that's for another differential. But it's not. It looks like an atypical chirpy, like a congenital hypertrophy of retinal pigment. That's why I prompted you. What is the correlation for the FAP that you're looking for? So it's chirpy.
For
If you
God, I
mention
need
chirpy, well and good.
to say it. So for God,
No, no, yeah. It's if it is like a bad track pattern, atypical chirpy or something, then we refer for the gastrologist or anything like that. Even then, not mandatory. You just refer to your GP and then they sort it out. Yeah. Okay, so that's good. We have one more station. Who are we? I think Bushra is going ahead with it. The last one. All right, Bushra. So start with the clinical picture in the right and then the left.
Okay. So this is a left eye fundus photograph
Mhm.
set to macula. And the most obvious abnormality I could see is there are multiple yellowish lesions throughout the posterior pole. And I cannot comment on macula, which seems normal. Optic disc look normal and retinal vasculature looks normal as well. And on the right side fundus photograph, that is fundus angiogram, fluorescence angiography, that is late venous phase, and the most obvious abnormality I could see is the disc, mild hyperfluorescence of the disc. I'm not sure. It looks normal to me.
That's all right. Just to prompt you again, could you look at the color fundus photograph? I'm not sure if the contrast is maybe increase the brightness or something. Could you comment on the macula again for the color fundus photograph? I'm just prompting you. That's it.
Yes, that is there is hypo. Uh, what is it called? Hypo surrounded by hyper pigmentation ring.
Mhm.
So it could be, bull's eye.
Yeah.
Maculopathy.
Right. You're right on the spot. Yeah. Go on.
Bull's eye maculopathy, but on fundus fluorescence angiography.
It's a different eye. Don't worry about it. So don't need to compare. So that's the left eye. This is the right eye FFA. It's all right. Okay. So could you give me your differential diagnosis, please?
So road crown dystrophy. It could be uh, road crown dystrophy only. Or,
Differentials, bit more.
mhm.
You have two things you can give differentials for over here: the
Target.
macula and the retina.
Target.
Yep. Can you give me more? Yeah.
Target disease. Retinitis pigmentosa, but highly unlikely because retinal vasculature is normal. There is no conus caucus.
Mm-hmm.
Road cone dystrophy. Drugs. Drugs can cause bull's eye maculopathy like hydroxychloroquine and hereditary retinal diseases.
That's perfect. All right. So, what more investigations would you like to do for this patient? Examination and investigations, please. Yeah.
Okay, so I would like to ask history in detail about if there is any night blindness or any color vision defect or age of onset. And is there any previous records available? And history, any field defect. And you asked for examination, so I would like to go for detailed anterior and posterior segment examination. Anterior segment examination to rule out any uveitis, if there is to rule out if it's birdshot, and uh, regarding your investigation, fundus autofluorescence, and electrodiagnostic tests like ERG and EOG, and genetic testing. I would like to ask family history as well, if there is any similar, in the family, in the siblings, and any history of drugs. Sorry, my approach is very. I cannot.
That's okay. That's okay.
Yeah, drugs. Any drugs like hydroxychloroquine or any.
Excellent. So how are you going to manage this patient?
So based on the symptoms
Mhm.
and investigations, It could be, so it depends on the diagnosis, but genetic testing. So I would refer this patient to for genetic testing.
Mm-hmm.
And else. So there is no conservative management, as this patient might need supportive measures.
Mm-hmm.
Uh,
Okay, so for example,
Depending on
say
the
this,
vision, sight impairment, registration, or something.
if I give you the diagnosis as Stargardt's disease, how would you um, taper your management to that patient? Say a
Stargardt.
15-year-old boy with vision of 6/24, and you've arrived at the diagnosis of Stargardt's. So management,
Stargardt disease management. I cannot think of anything other than genetic testing.
are you aware of the gene?
S. Yeah, I think it's ST. No, I'm not aware of it.
That's okay, no problem. Okay, so your differentials were good. It could be any of that. We would Rod-cone dystrophy, retinitis pigmentosa, age-related macular degeneration can also be one of the differentials. And you can tell what else differentials have you? The ERG, EOG was a good point. I have not marked you down for that. And bullseye maculopathy, you have to have a list of drugs. I am sorry, I don't have the list of drugs with me right now, but make a list and so you can quickly tell. And the idea of putting the FFA here was to comment on the dark choroid. You
Yeah,
can, yes,
yeah.
that was the plan. Was it ABC4? I think that was the gene that I was.
Yeah, it's
for the-
ABC4 gene.
Yeah, so that was the gene for Stargardt's disease. And for Stargardt's, there's no particular treatment. When I asked for management, you will have to quickly tell, you will counsel the patient, genetic examination of other family members, and low vision aid. Those are points that you can add.
I
You
think it's all about the visual rehabilitation. Yes,
Yeah.
just gross term of that should also help. But otherwise, yes, I think most of it was covered. Shweta.
Yeah, differentials, I think she get good. She needed a bit of prompting, but in the end, she got to all the points. So in these conditions, you will pass despite telling all the points. You will be losing 1 mark for the prompt. That's the problem.
Mm.
But very good attempt. I know you're still in the preparatory phase. When you just before the exam, you will definitely ace these stations.
Thank you so much.
Oh,
You
just
gave
as
me
Ahan
confidence, to be
corrected.
honest. I wasn't confident, but with first station, you gave me confidence, so I got ready. with
That's
second.
okay.
No, that's good
That's how
actually.
you do it. So I would tell you, when I was starting to prepare for this exam, I was already doing cornea for 2 years. I had even forgotten how the retina would look, and I used to struggle. I've had this conversation with Dr. Shruti multiple times. Like I can't even think this is something you would know, but
Yeah,
it
don't even honestly.
so it's just constant practice. Having a study partner or a study group makes a huge difference, because each will keep reminding you, they will know your faults. So that's a good thing, but good, very good attempt.
I think we're going on to the so small correction there. It's ABCA4 gene.
Yeah,
Ahan has pointed
ABC.
out correctly. Yeah,
Correct.
sorry about the mistake. Yeah, so we'll go to the communication station. So what we'll do is we'll give you 2 minutes. You guys have a read through it. If anyone is interested in being the patient, sorry, the doctor here for this scenario, just raise your hand. If not, me and Sweta will have a go at it. So we'll put a timer, 2 minutes. Just have a go at it, guys, and we will come back to it.
Dr. Bushra, have you raised your hand for this station, or is it from the previous station?
It's the previous one.
Previous station.
Okay, okay.
And I think Merin has put in the group if who and all are giving exam in October. So if you guys want to, form like a study group, that would also be great.
Yeah. If somebody wants to do this, then we will help you attempt the comp station, or Shruti and I will give a demo, and then we have one more station which you can attempt.
Would anyone like to attend, or would me and Sweta have a go at it?
You can type it in the chat box, guys.
Good
Anybody?
demo by you, ma'am, will be very good for us to know
First
how.
to go ahead. Oh, wait. Okay, fine. Yeah.
Okay, all right. Then,
Shweta, I'll be the patient. Come on, you be the doctor.
okay, sure, no problem. All right.
All right. Okay. So, yeah.
Okay. Good evening, Mr. Dave. How are you today? How are you doing?
I'm all right. Thanks for asking.
So did you come driving, or has someone come with you today?
No, I just came in with my partner because I know we'll put the drops in for examination. So, yeah.
So did you drive?
No.
No, you haven't. That's good. That's good. So how are you doing after the cataract surgery? I understand from your records you had a cataract surgery recently. And vision-wise, I can see from the records you're 6'6". That's excellent. How are you feeling?
I'm feeling quite good. I'm satisfied with the vision, but I just noticed that it's just a bit duller than before. I don't know if is it something to do with the cataracts or something? I'm not sure.
Okay. Mr. Dave, I have to give you some bad news. It's not very grave, but I'm very sorry to say your pressures have gone up, and the regular glaucoma tests that we did today, the field tests that you do in your follow-up, that's shown a bit of advancement or progression.
Yeah, I did notice I had a bit of a difficulty when I did the field test. I thought after cataract it should get better, so I'm not sure why it happened.
Exactly, it should get better. If I may ask you a few questions, along with the cataract surgery drops, did you take your glaucoma drops as well? Because on the records, I can see that you are on one of the FRCOphth drops with a combination, but have you been taking it?
No, because I wasn't actually directed to take them. I thought because since we had the cataract surgery, I don't need to take them till I finish the medication. Was I supposed to do that?
Yes, Mr. Dave, you were supposed to continue the glaucoma medications.
But
May I ask
mean,
it was in your discharge summary?
no, I did receive a discharge from the theater team, but it had only the two medications for the one that we use after the cataract surgery. Was it some steroid? Was it?
Yes, it was a steroid and antibiotic. So
Yeah.
not using the glaucoma drops has kind of made your pressure to go up. And that has also resulted in progression of your disease. So I'm very sorry that this happened, Mr. Dave. I do apologize for the lapse in the discharge summary that was given to you. Very sorry this happened, but I have to say you will have to inform the DVLA. You generally drive, I'm aware of that, but with this advanced fields, it is difficult for you to continue driving unless we've done the tests and confirmed that it's not affecting your regular driving. And we have to restart the glaucoma medications. 30 is high for the amount of glaucoma that you have. So we need to bring it down. And I will restart the glaucoma drops. I will recheck your pressures in a week. I will be booking you into the glaucoma clinic for further follow-up. The next few months, it's going to be a close watch with the glaucoma team. And I'm giving you too much information. I understand.
Yes, yeah,
Following
it is
what
a lot. No, what I don't understand is I followed the instructions that was given to me by the medical team. So I get it. You did mention that there was some error in that. First, I don't understand how that happened and why I wasn't given proper instructions. And the second thing is like I need to drive. I am the sole caretaker at home. I have a partner who I need to take care of. I need to take them to the hospital for their checkups. And there is like, it's almost every other day. And I'm the sole caretaker. And without a car, it's almost close to impossible for me to function with my daily activities. So you saying that I can't drive, it's another thing. And it's not like it's my fault. It's the fault of I don't know whose fault it is, but it's someone's fault for putting me at this position. So it is a bit too much for me to take in at this time.
I am sorry. I apologize. I know this is not entirely your fault. In fact, it's not your fault at all. We should have written it down in the discharge summary. I am going to report that this happened. I'm going to find out why this happened, have a chat with them, make sure that this does not happen again. I can direct you to our system for you to make a formal complaint as well. I'm very, very sorry this happened to you, Mr. Dave. This should not have definitely happened. I sincerely apologize. I will do everything that I can from this point to take care of you. But at the moment, I really have to ask you to stop driving. We will do some tests to see how if you can drive or not, but you have to inform the DVLA because the fields have progressed. This particular field test that we did today would not define if you can drive or not. The DVLA will repeat a particular test and then tell you. So for the time being, please inform the DVLA that you will not be able to drive. We will bring your pressures down, reassess, and take it from there.
I'm not very keen on complaining. As long as this situation is properly assessed and this doesn't happen again to anyone, I'm okay. But I would need to know what happened and why this happened. I want to be informed about this process. Could you just make sure that happens for me, please?
Yes. I will be making a report. We call it the DATIX here. I will make a report, make sure it is investigated. I will direct you to PALS where you can register and make sure that this investigation is over and we will relay the information to you. I do apologize again. I'm sorry this should not have happened, but we will make sure your appointments from now on is taken care of. We will restart the drops. I will write down a prescription or a format as to what drops you're supposed to take. In a week's time, we will recheck the pressures. I will notify my glaucoma consultant and team as well. So we know that this has happened and we'll keep you under close watch. Your vision is fine after cataract surgery. Your vision is really good, but the contrast or the dullness that you're experiencing is because of the field that is getting affected.
And is there any way we can get that back, like when you start the treatment?
To be very honest, I don't think so. But there has been some circumstances where they recover to some degree. We would see that in children. We haven't really seen that in adults. And I'm not the best person to comment on when it is not my specialty. I will direct you to my glaucoma team who will give you a better picture and how to go about this. I'm sorry, Mr. Dave. I'm very sorry.
I mean, at this point, I don't think there's anything that can be done. I just really hope that this thing gets sorted out and I can maintain my pressures come down and everything gets sorted out. Yeah.
I hope so, Mr. Dave. I will also give you our secretary's number. So we can give you a point of contact to, if you have any doubts when you go home, so you can ring us up at any time. I will also give you my details so you have a reference to whom you've spoken to today. Is there anything else I can help you with, Mr. Dave?
No, I'm all right. Yeah.
Thank you.
All right. Thank you. Okay.
So,
I think that covered it. Before we go into it, Sweta, I'm wondering if others can actually comment on points that they think were missed or
yeah,
they think were the highlight of the the communication skills.
because I know I missed a few points. If somebody can point it out, it'll be nice because I missed one first section that I was supposed to do. Yeah.
Yeah. So
Can I say something?
Yes, please
yes.
go ahead, Fahad.
Hi. So I mean, obviously you mentioned, but should we use the word duty of candor, or is it like self-explanatory in?
You can use.
You can use.
Can use.
Okay.
It
And
can
the other
use.
thing, I mean, you did mention that doing a report, but I thought maybe you should use like the word incident reporting, obviously because you mentioned DATIX, but a lot of different trusts have a different system now called in phase and different kinds of incident reporting. So yeah, I mean, so,
Yeah,
I know.
incident
I
reporting
mean,
is a good idea.
yeah,
Yeah.
I mean, obviously, like you guys are like the mentors here, but I mean, I just thought that if I had like one point to say.
Well, we're not the mentors here. We just gave the exam last session. We are always welcome to ideas, but that's a very good point. Different trusts have different things, so it's
True.
better to say incident reporting. You're right about that.
That's a good. Yes, that's a point we wanted to add. Anyone else noticed anything else, or do
But
you have any more points?
I mean, I think 99% everything was covered. Like point of contact, giving details, offering all kinds of support, DVLA. I mean, yeah, I don't think. I mean, this was like definitely like a full pass score.
Okay. The main thing I missed was establishing rapport. So in the exam, the first thing you're scored at is establishing a rapport with the patient. So I have to first say, hi, I'm the consultant today. My name is so and so. And I have to check, can I please check your identity and your date of birth? You had the cataract surgery done on this day. Can I speak to you? So that establishing rapport with the patient will carry 2 marks. So that's the first thing I should have done. And after that, I would have said, so did you come driving to the clinic today? So that is the point that I miss.
Yeah.
Thing is, we always forget driving, so we make sure we comment on that, and that's why we start with driving.
Yeah,
Yes.
so
Well,
I wanted to demonstrate this particular station to say that you can quickly ask, how did you come to the clinic today? Instead of asking, do you drive? So that kind of makes it look more natural in the exam and to exhibit to the examiner that you've been doing this every day and you know what you're doing. That was the whole idea for doing this station. And to for people writing this exam or giving this exam from outside the UK, we have different systems of reporting this. So the patient goes to a system to give his concern that's called PALS, PALS. I'll type it in the chat box. And there are different incident reporting which we can do to our colleagues, or when you want to do an incident reporting, like I had a needle stick and then I had to do something called datix. And like how
yeah.
Dr. Fahad had just pointed out, different trusts has different things. So you can
Thanks.
just call it incident reporting as well. You will not be penalized for not mentioning the names. But if you mention the names, you will get marks, and they know that you know the UK
and
system.
and and I mean, one more thing I would have mentioned to the patient was that, we class this as a serious untoward incident, SUI.
Yes,
So, and when this happens, we do like a proper root cause analysis to see where the lapse has happened. We would investigate and, make sure that this doesn't happen, and we'll get back to you with the outcomes of the investigation. So we'll let you know what the outcome of the root cause analysis is.
yes, yes. I agree. I completely agree. So there are few events that we need to study about and define, like a never event, a serious event. So those are things that is given in the blue book, and you need to memorize the definition. Mentioning according to the duty of candor. Duty of candor is to tell the patient what actually happened as it is with full transparency. So I told, I'm very sorry, this should not be happening. So that is duty of candor. So I didn't want it to be unnatural. So I said, I'm very sorry. So things you scored on is establishing rapport, being honest and explaining to the patient how you explain, that is seen, and you have to apologize really sincerely. So apologizing many times carries score in these sort of scenarios that is given to you.
So yeah, that is true. It matters. So I think in this station it will be like one examiner and the patient, and then yourself. So it is they will ask the actor as well how they felt personally. They will
Yes.
feel genuine or not. If the actor gives you a low score, then that also is like, and sometimes they will cry. They can be a bit more aggressive than what we are. So you just need to be able to hold on to your, cool, not let go of it. Just don't get startled if they do something really different or weird. Mm, but yes, some
If they
points.
cry, just say,
Yeah.
I'm very sorry this happened to you. Because I kept saying, I'm sorry, I'm sorry. That's the only thing you can do. And that's
Yeah.
say, I'm very sorry this happened to you. Can I offer you some tissues? Can I offer you a hot beverage? Would you like to sit down? Would you like to take a break? In the exam, it is okay to say that. That shows that you care. It is not mandatory that you have to complete the station and come to a conclusion. It's how you demonstrate your empathy is what is matters. You really have to be empathetical to the patient, and you should be very polite. Apologize. Here we are, the doctor is at fault. So apologize. Don't get defensive. If the patient is aggressive, you still apologize and say, can I offer you something? How can I help you? Something like that. Say, is there someone with you? Who would you like to be with you at this time? So ask permission and do such things. These are small things that will add to good marks.
So I think to summarize the station, so many station always introduce yourself, identify the patient, easiest to do is date of birth. You can also tell them, can I address you and so and so, like if they have two names, you can always ask that. And then you go forward. So this was duty of candor, incident reporting, PALS, and yeah, that's
DVLA.
and DVLA. Yes. So she almost covered four points in a single station, which highly unlikely to happen. But these are the things that you need to think about, because other stuff are easy, like when there is like a normal communication and everything, it's not really that difficult. But only when the angry patient or unhappy patient comes in, it gets a bit tricky.
Okay, so any volunteers for the next comp station? Do someone can
No.
be the doctor?
Just tell them it's not an angry patient.
Oh yeah, it's not an angry patient. It's an easy one. So, uh,
Is
Ahan's.
Ahan's raised, Bushra's raised. Do you guys want to? One
Okay,
can
you
be the
can do it on
doctor,
each other. Yeah, one can be the angry patient. One can
one
be
can be
the
the.
a doctor. So I'll display the scenario. Both of you read and
Just
then
have a look at it. Yeah.
have a look at it and take 2 minutes. Write down points, and then you can tell who wants to be the patient, who wants to be the doctor. Yeah.
So, who am I, mother or doctor? I
Okay. Yes, you can be the mother, or what do you want to be? You want to attempt the station? Yes, you're welcome to.
I don't mind becoming.
Okay.
Yeah, anything.
Ahan, do you want to be the angry patient?
Anything is fine with me. However, the surgeon's position I feel is so unexplainable. I mean, if I'm the performing surgeon and this has happened, then that's so tragic. I don't know how to count.
You will get these things in the exam.
What
Yeah.
reason, what reason should I give for doing
Yeah.
so?
No. So, but Aha is the patient. Is it
Yeah, Ahan is the patient. You're going to be the angry mother.
angry mother? Yes. Come on.
Okay. Okay.
Okay. Go ahead. You can turn the cameras
Yeah,
on and
camera's on. You need to be. It's like it needs to be face to face.
yeah, you have
I
to
think.
be
Sweta, take off the PPT, no, so that it's more
yeah,
enlarged the face to face. Yeah.
Or
Okay.
I think
You need to engage.
they can pin our like
Yeah,
screens in
maybe
the panel, and our faces will be
I
more visible.
have I have pinned yours and I will pin. Uh, Bushra, are you able to come on
Give
video?
me just a second.
Yeah, no problem. Yeah, because this is very important in terms, because you need to address the patient, the communicator's facial features as well. So once that's that, I guess.
it really matters to have the right expression. You saw how serious I was looking at Shruti saying, I'm very sorry this happened. So you need a bit of acting skills as well for this station. So
So
be
I
very
will switch
when we
on
practice,
the timer. Yeah.
there were times when we've laughed on each other's faces. Just don't laugh. That's a definite fail.
Definite fail.
Yeah.
Yes. All right, I'll start the timer now, guys. Go.
Hello.
Hello, doctor. I'm very curious. My child, how was the surgery? May I please know?
Okay. I'm going to explain to you everything. Before, let me introduce myself. So I'm Dr. Bushra. I'm the operating surgeon, and operated on your child today.
Okay.
I'm going to explain to you everything. Before that, before you that, will you please tell me what exactly was the reason for the operation?
I noticed when he was 1 year old that he had um, the left eye deviating, like the left eye moving outwards. It seemed a bit wandering. I got concerned. It didn't look correct. So then I consulted a doctor, and he advised that my child does need surgery, and that will be something that will be very helpful for his vision, and also for his the growth of the
Yeah,
eye.
yeah,
So can
yeah,
you let me know? I'm now very curious what happened
yes,
during the surgery.
yes. I'm going to explain to you everything. Will you please tell me how should I address you? Is it okay for me to tell you? Uh, how would you like me to address?
You can call me Jane.
Yeah. Okay, Jim. So the thing is, I'm extremely apologize for the thing. I have a
What
bad news.
happened?
I have bad news for you. The thing is, uh, Mr. No has a problem with his eye, and that we call it squint. There is radiation, and unfortunately, it was there was a mistake in the operation. So he has a problem with the left eye, and unfortunately there was a mistake from my side that I operated on the right eye. So I extremely apologize for this. I understand that there is no explanation. Sorry won't be enough, but
How is that even possible? I got all the checkups done. I was coming so regularly for my boy's health, and you are saying that it was urgent for his vision, for his growth of the eye, and now you are telling me that that eye is not even operated, and the other eye is operated instead. Now I don't know. I don't know what to say. This is so bad. I mean, I consulted the doctor so many times, and then finally the call for surgery was taken. Doctor, can you please explain yourself?
Miss Jim, I can't even imagine what you are going through right now. These news must be shocking for you. I understand that, and I extremely apologize for this. But I am going to tell you what I'm going to do now, if that's okay for you.
I am actually very angry, and I cannot even process what is being told to me now. Now, there may be the need for another surgery, is what you may tell me. You may also. I talked with my husband yesterday about the surgery. I was so nervous. My child did not have food before surgery, and now this has happened. I actually am very, very much concerned. This was our only child, and I want to raise a complaint for this. I want to get it formally addressed, and please give me a valid reason why I should not get a case suited in the court for this.
Yes, Miss Jim. I understand that you are quite angry, and I'm going to uh, help you to raise formal complaints. So we have a service called PALS, Patient Advisory Liaison Service. So I'm going to give you leaflet as well. So to make sure, there is a guidelines how to make a formal complaint. You can go through it. And regarding this mistake. I'm very sorry and I apologize for this. And I understand that being a mother and he had to be, he didn't eat before the surgery and he was operated on the wrong eye. So it's not like something you were expecting. And, but there is, what I'm going to do now is I'm going to we call it root cause analysis to find out what exactly happened. So was there any problem with the marking the eye or with the records or what? I'm going to there will be a meeting and we are going to find out exact reason why this happened, and it will be open and transparent. So whatever is the mistake we are going to inform you as well. Whatever will be the outcome, we are going to inform you as well. How does that sound?
Okay, I'm actually okay. Given the explanation that you have given now, I want to know what will be the step from now onwards. Let's say I am willing to let go of what has happened. Now the wrong has been treated. Can you tell me what will be our current plan of action, and how
Def-
things will go?
Definitely, I'm going to explain to you everything. So what we are going to do now is we are going to examine him post-operatively to check how is his deviation. Okay, so if it's sometimes the thing is depending on the deviation, we need to reoperate him, and we this time we will make sure. So it depends how much deviation he has, and depending on that, we need to operate on the affected eye. Okay, and I'm extremely sorry, but I will assure you that this time there won't be any mistake, and we will make sure that we operate on the correct muscle and correct eye.
Okay. Thank you, doctor.
Do you have any? Is there anything I can help you with?
Yes, I'd like to know how things will proceed like immediately from now onwards. I understand that you are telling me that we'll assess the child, but what about my visits? I am coming from far for this surgery. I was consulted in Cardiff, but I have to come to London for this. So that is again something that's very troublesome for me, the transits and all.
Okay, so I'm going to liaise with your consulting doctor in Cardiff, and for post-operative examination and things, you don't need to come all the way London, and we are going to we are going to be in contact to find out about the progress, and depending on his recovery of this current operation, we will decide for further steps, or if he needs surgery, we will contact you, and you need to come to London for the surgery, but not for routine follow-up, if that's fine for you.
Okay, and meanwhile, I was told that the surgery was urgent. Now that the surgery is delayed, what are you going to do for the child's left eye, which is actually having this wandering nature for the past 1.5 years? I'm very concerned. If my child doesn't have vision, doesn't have the potential vision that you told that may come, this is not
1
helping
minute
that.
left.
Okay, I understand, James. So we call it amblyopia. So we are going to monitor him closely to prevent any vision loss and for his vision development. So let me summarize everything for you, if that's okay for you.
Yeah,
So
yeah,
what
sure.
now? So there was a problem with the wrong surgery in the wrong eye, and I extremely apologize for that. And what we are going to ask for regular follow-up and to check his vision, as this was urgent. That means we need to prevent amblyopia, or we call it lazy eye. And for that, we are going to monitor him closely. And depending on the recovery of the initial surgery, we are going to as proceed with this next surgery as early as possible if it's required. Okay.
Thank you, doctor.
I again apologize for what has happened. Sorry. Thank you.
All right, guys. Well done.
Thank
Very good acting on both sides. Ahan was a very strict mother.
Even the
It is
scenario,
for Ahan to
the
be the
scenario I
angry
thought,
patient.
yeah, I had to be a bit more tough.
Yes,
Yeah,
yes.
you
I
have to
think
know now
you'll
that
score
it's
like
actually
full
true.
marks if you're the angry patient
Yeah.
exam.
Yeah, it's good. I think, Dr. Bushra, you covered very well. It was nice the way the rapport of the conversation went. It was in a very good direction. It's good that we direct the way it goes. Like initially, you apologize, get it out of the system, so that you can go into what's the further management. Sometimes, otherwise, if you try to sort of keep patching it up without, directing the patient towards let's finish this, move on to the next aspect of it, you won't be able to finish the communication skill. That's how many people kind of lose points. You did introduce yourself very good, but you did not confirm the child's name. So are you so and so's mother? Yes,
Yeah.
it's just a small thing, but yeah, always.
Actually, initially I forgot the name of the child. So
Yeah. So in the exam, they'll give you a paper, a pencil, and 5 minutes to prepare.
Yes.
You
So you
can
can
write
write down all the
whatever you
points.
want, but first write the name, because that's the main thing you need as soon as you go in, the age, and then go ahead and then make a plan for yourself. Like I used to write stuff like DVLA, duty of candor, everything, so that you
Yes.
know. And then you can just act out stuff like, I hope I've told you everything. One more thing I wanted
You
to
can,
talk to you
yeah.
about. You can do that. but don't go like, I want to talk to you about this. Don't do the list, but be like, I noted a few points that I wanted to discuss with you. If it's okay, I'll just quickly take a look. So you can look at your paper and then go ahead. Just make it very smooth.
Okay.
So I've put down in the chat box as to how you will be marked in this particular station. So establishing rapport and information gathering, both the examiners will do. That is, the patient and the examiner who's sitting inside will do. That's 3 + 3, 6 marks. Information delivery, the examiner will do. Understanding of the information delivered, the patient will do, who you're speaking to. Appropriateness of the advice and accuracy of the information, the examiner will do, and the patient will give an input. So both of them mark you down, and it's scored out of 18.
Okay.
So, yeah, I think it went well. Overall, you guys actually covered it all. So point wise.
I'd like to just say that I think in these scenarios with a surgical mishap or whatever serious untoward incidents, patient may have, like, I was trying to act on the Kubler-Ross's theory of denial, anger, bargaining, depression, and acceptance. So maybe if the doctor knows it, like, this is how the patient may respond, and then structure his interview accordingly, maybe a bit more helpful.
Yes, yes. But
That's a very good point to add. Yeah, yeah.
she apologized, did everything. So maybe to gain marks, you can say, I'm being very honest with you to say. And in the beginning, when you say bad news, just ask, I have some not so good news for you. Don't use bad or worse, because immediately they think that
Yeah.
happened with life.
Yeah.
So,
I don't.
one of my practice sessions, it was like, is my child dead? That was the next question they asked. So don't do that. Just say, I have some not so good news for that. Would you please take a seat? Are you alone today? Do you have someone with you who would like to sit with you? So just bring that in here and there into the system. So that's one thing I've written. You apologized sincerely, so you will get marks for that. Appropriateness of the advice and accuracy is okay, and then the patient will give the input. I think Dr. Ayman has raised his hand.
Yeah.
Ayman, would you like to add something?
Yeah, thank you so much. Very nice performance, actually. Because I have missed the start of this station, will there be a station in every exam, like regarding these issues that you have mentioned?
Yes, the communication station will have, it can be a never event, a serious incident that's happened, wrong eye injected, forgetting blocks. So Shruti and I did her demonstration. I think you missed that. So they can ask you about a missed glaucoma drop and the glaucoma progressed. So in the blue book, there is I think chapter 6, it gives you different events that can be wrong lens implanted, refractive surprise in a patient. Cataract surgery is done, other eye cataract surgery is planned.
Same. Yeah.
Patient is not happy with the other eye because she was a high myope earlier and now she's ametropic. She's extremely unhappy because she can't do near work. So they can different scenarios, and then you have to address each thing. So just our advice here would be, try and practice various scenarios, have a list as what you would do, have a structure, how you're going to establish a rapport. And there are a lot of hands raised.
And just one more thing, Dr. Swida, will it the candidate will always act the doctor, yeah?
Yes,
they will not
yes,
ask us to
No,
act, yeah.
No,
Silly
no.
question, yeah,
We
but
just did it because there were 2 volunteers and
yeah, that's fine, yeah.
You will have an acting patient there, and the patient is one of the scorers for the exam. So I put in the chat box like who will score what. Just go through the scoring system. 1 examiner, 1 patient, and you. 5 minutes time preparation before you enter the station. You'll be given a paper and pencil to note some points which you can use.
And 5 minutes to do the
10 minutes
10
into
minutes.
the station.
And that's in the OSCE exam. That
Yes,
will be,
yes.
yeah.
It will be, it is, mark is calculated with the OSCE, but
It happens during Viva.
Viva.
Oh, so it's in Viva, okay.
Yes, okay.
One other important point in this station is it also, we need to be clinically sound because, for example, they won't give us a straightforward diagnosis. So based on the clinical scenario, we need to diagnose, is this a AMD patient? Is this
Retinoblastoma.
tumor? Yeah, it's a tumor. What is it? It's a clinical scenario. So unless we get the clinical scenario correct, then the entire station just goes wrong.
Okay.
So that's another thing we need to think about.
Just one more thing for this scenario. it's not related to the communication, but because I'm a strabismus surgeon, so we always tell the patient when we do the consent form, it's not a matter whether we operate on right eye or left eye because it's an angle. But I will assume that the scenario will be operating on the wrong muscle rather than wrong eye.
Yes,
Because whether you do recession for right medial rectus or left medial rectus, the result will be almost the same. We do always try to operate on the deviated eye, but sometimes the patient might have bilateral deviation. So yeah, I will assume that the scenario will be maybe operated on a wrong muscle or did recession rather than resection.
Yeah, could
So
be.
the patient was XT moderate 30 angle, ended up after the surgery 50 or 60 angle XT. Yeah, just a small.
The most common would be injected the wrong eye. That
Mhm.
would be the most
Yeah, that too.
wrong lens implanted,
Okay.
refractive surprise. These are the commonest
Yeah.
scenarios. Yeah.
Okay.
I think Dr. Beena, your hand is up.
Yes, I was thinking that I'm not sure if I heard, but as soon as we start the conversation, the doctor should inquire to the mom that how is the child doing? Are they okay? Are they have you noticed any problem post-operatively? Are they comfortable? Do they do their routine activities as normal? Or have you noticed any increased deviation in any of their eyes? So we can start with that conversation and see how seriously mother is felt that the child is affected, and
Yeah.
then it can be taken
Yes.
from there.
Yes,
That
yes.
may
No,
be
yes. I mean, I think, yeah,
Actually, in this station, it was
yeah,
just immediately after
immediate
the
post-op.
surgery. So I
Yeah.
think he might not come out of G or something, right?
Yeah,
yeah.
exactly. So it's very important, Dr. Beena, because you need to, the situation was immediate post-op, and we are
Yes.
already informing the mother before they even take the child home. The child is still recovering from anesthesia. So
Okay.
we are having a chat here with the mom before they can go home.
Yeah.
So,
So
but
we
that's
don't know
another
how.
thing. Yeah,
Yes.
don't
Yeah.
know.
Okay.
Yeah, we don't know. So
Okay.
we're
That's
just,
fine. That's
But
fine.
if it is in the OPD, I would agree with your approach. So you can
yes.
approach it the way you do also. That all comes under
Yes.
rapport, and I would agree that way.
So mother should feel that we are still caring for the child, even though we might be wrong somewhere.
Yes, yes.
Yes.
Okay. Thank you.
Thank you. Dr. Fahad, your hand is raised. Any inputs?
I just wanted to ask one question. Do we, so we know this is a never event. Do we have to tell the patient, like, because obviously for us it's a never event, but do we have to tell them that we consider this very.
Yeah, so when I was preparing for the exam, I had the same doubt, but then I thought to exhibit to the examiner that you know the system, you can probably make a mention telling, oh, this never should have happened. It's a never event, but this happened. I'm so sorry.
We
So
consider this
that
very
way,
serious, and yes,
yeah,
and I completely accept my fault, and
yeah,
this. So okay, so we should use the word, because I was just thinking of getting that 1 mark for using the right terminology.
exactly. We don't do it in our daily practice, but
Yes.
in the exam, it's everything is a bit
Yeah.
dramatic. So I would
Yeah.
suggest that you use it.
Okay. Thank you. Thanks. Thanks.
Sorry, can I just
Merin.
ask
Oh yeah,
quickly?
all right, Beena. Yeah, go
Yeah.
ahead.
So if you say mention that this is a never event and it should not have happened, what are the steps for the that we as a doctor should take when the never event happens? That we should discuss with the patient that this is a never event
Yes.
and we are going to do these steps, because
Yes.
normally we won't do those steps,
Mm.
because never event, I think, do we need to report to GMC? Is
No,
it?
no, no,
No,
no,
no,
no. Nothing goes to the GMC from
GMC.
us. Yeah, we
No,
just put
I
an
means
incident
is
report.
there any different protocol we follow with the never event? Because
No, it's basically goes as an incident, and in the incident, it is categorized as a never event. Like there are different ways, like serious incident, never events, serious events. So you need to know definition of each one. Again, that comes into your attitude ethics as well in Viva. So they will ask you what are never events, what are serious incidents. like what do you categorize as an incident report? Like, so you need to know now that is all there, multiple stations are there. So this same thing, you tell them you're going to file an incident report. It is categorized as a never even. So basically it should never have happened. And we will be analyzing where it went wrong. We can also add that we have a timeout before procedure to make sure these all doesn't happen. But this has happened even after doing all this. So we need to find out where exactly things went wrong with the documentation or marking, same way marking the eye, so many things. So we don't know where exactly it went wrong. So it's not like we are going to blame one person. There is some systemic error which has led to this.
And we should mention to them that normally we have like 4 checks like in the ward by in the time out, sign in, and all those things. We have multiple checks, but unfortunately this has slipped through all the checks, and this is like a very serious event for us, and we'll investigate. And so we should like mention that as well, right?
Yes.
So
It would do so in your favor.
But as a surgeon, take responsibility, right? Not try to shrug responsibility, but take responsibility.
So if this is an attitude and ethics station, then defining a never event, going through the steps we do after a never event, mentioning the WHO strategy that we do, timeout, ward check, all that you can go into detail. But here in comms station, all these telling these few points is going to be going under only appropriateness of advice and accuracy of information. So for that, you have to just tailor it to that situation. You will be marked more on how sincerely you apologize and if you have conveyed the information and done the right thing by the patient. You will not be marked down because you didn't mention never event or because you didn't say about the WHO effect. You will be just see what station and accordingly give the weightage there.
Yeah.
Because trust me, we will want to add so many points, but the time, it's a nightmare. So we will run out of time before even we know it. We need to summarize in the end. It's that last 1 minute. I think we get a timer, isn't it? Like
at
1
9 minutes you get a bell. At that bell you just say to summarize what I have told, and then you can just quickly finish telling I know we haven't completed our conversation, but I will give you a point of contact. I will give you information leaflet. If you have any doubts, you can come back to us. So just finish it with that standard so they know there is someone to reach out.
Yeah.
Any more hand up?
Merin still has her hand up.
Hi. Other than the information that is given in the leaflet, can we just say that it's excellent that you have got 6/6 vision? So can we add things so that it makes it easier for us? So can we add things? I can see that this is good. Like even if the vision is not mentioned.
No. Usually it will be mentioned. It will be like a very elaborate list. It will be almost 1.5 pages that they give you an entire thing with so many details. So just for the sake of ease, I just shrunk it and put like a summary. But when it is an elaborate thing, note down small things that you might miss, like vision, IOP, and all that. Small things you take and you write it.
Okay. I thought just few sentences will be given and we can add on to that.
No. It will be at least a page.
Or at least half a page. Not always very big. Depends. Yeah.
I think we cannot mention anything that is not given, right?
Yes.
If we can say I can check the system, but we cannot give, like, we can assume about anything, right?
Yes.
No, don't assume. Yeah.
Don't assume. Don't make up stuff. Just say, I can check the reports, or I don't have it on my records. Can I ask you how your vision is? You can do stuff like that. Okay.
I think no more questions.
Yes. I hope you guys benefited from this session. So our course is going to be something like this. We have given the timetable also on the group, I think, or we'll reshare with the timetable. We are coming up with a library for the important guidance, MOLS criteria, various criteria that you need to have tips for the exam. We'll publish it hopefully in a week to 10 days. So everybody who's giving the exam benefits from that. So our small group teaching, we are also aiming it to be within 10. So everybody gets a chance to discuss various points, because we gave the exam a year ago. We might have forgotten a lot of things. Like when people bring up stuff, it would be helpful for everybody. That's the idea of small group teaching. And a mix of people, few given last time, just missed it by a whisker. A few who are practicing in the UK, some are outside the UK. So a varied group also brings in a lot of points for practice. So register, if not, reach out for any help on the group. We will give you our input and feedback. Any doubt, just post on the WhatsApp group and then we'll reply.
But thank you so much, guys. Today was a very interesting mock session. I'm
Yeah.
happy that first timers had the chance to sort of have a interactive session, because this will give you an idea of how to start the preparation. And this is the way you need to start the preparation. Don't go reading page to page. Doesn't work.
And this is the best way to form study groups as well. Do let us know if you need help with the study group sessions. We can see how we can help with that as well.
Thank you so much.
And
just-
we'll post a small feedback form on the WhatsApp group. So please do give a genuine feedback and what you expect more from us so we can help you with the sessions.
Thank you very much.
I'd just like to convey that this session has been immensely, I can't emphasize this enough, beneficial for people like us who are not familiar to the systems, to the guidelines. Although we have given the written exam, but still there is so much to know. And I personally would like to, like, I have a short like Instagram page. I'm helping out PGs with ophthalmic education, and I'd like to take it step further. I'd like to maybe put a photo or convey a short recording, if that's fine, and promote both of you, because this is so helpful for all the students. And this is something that's very generous of you to teach us about. And thank you very much. Today's 3 hours were, I don't know how fast they just went. And it was immensely helpful. Thank you so much.
No problem.
Thank you so much, Ahan. That
Very,
was
very kind.
nice of you. I'm happy you were able to make it today. So any other questions, as Shweta was telling, please feel free to put it in the group chat or reach out to us, and we'll get back to you guys. If nothing else.
Yeah, I would like to thank you. I agree with Ahan. It was really very fruitful and very, very great. Actually, it touches the defects, which I feel that the knowledge is there, but it's the way how to deliver it, how to treat with the patients. It's really very, very beneficial. Thank you so much.
Thank you.
Can
Thank you.
Thank you, Dr.
Yes,
Aiman.
can I just ask Shweta, that is it possible to get a recording of this session?
Yes, we will be posting. We will be posting it on the WhatsApp group, the recording of
Thank
this
you very
session.
much. Thank you.
Yes, yes.
Hi, Shweta.
I'll get in touch.
It was a nice session. And I think so. Other participants like Hemali, Rachana, and Shruti, they are my friends. Like they have joined today. Can you enlighten
nice.
about the session so that like there are already they're having a preparation group and preparation is going on.
Okay, that's very nice of everybody to join today.
So we can.
Mumbai, and Rachna, she is from Bangalore, and Shruti, she is from Jipmopondi.
Okay.
And
All right.
can
I mean, we can, if they, I don't know if they've attended the previous sessions, we can give them, Sastika, maybe are they part of the group in the WhatsApp?
no, I think so. I
No.
thought this is the first session. I don't know.
No, we
There's
had
we have a WhatsApp group. We'll share the link. So please pass it on to you, and then you can be well informed of any further sessions, and we can help with the study group sessions.
Okay. Actually, they are doing November exam, not the October exam in India. They're taking
Oh, that
the
will
November.
be good then. Yes.
Then it will be very good for them because the course is aimed at
Planning is for now.
November in the UK.
Like you can
Sorry,
tell
Shweta,
about it.
I'll just
Thank you.
take off for the
And-
moment. I just got a patient to see.
Yeah.
You guys just carry on. Thank you so much, everyone.
Shruti.
See ya.
Shruti is
Thank
on
you.
call, so I think we should.
Okay,
Sorry,
can you
Shruti.
course
Hey.
and can you tell about the course in detail, like all about your sessions and all, so that they'll
Yes.
get to know about it in detail.
Absolutely. We'll send the WhatsApp group link and join the WhatsApp group, and I will also share the course details and everything.
Sure.
Okay.
Thank you.
Okay. Meeting you, and thank you everybody for
Thank you all. Thank you.
joining you. Bye-bye.
Thank you.
Bye.
Bye-bye.
Bye.
Bye-bye.